Good morning, everyone. Thank you all for coming. Good morning. Hi, everyone. Hello, good morning. Welcome, everyone, and thank you all for joining us today. We have an exciting educational seminar today, and we appreciate everyone's participation. My name is Natalia Nekaridze, and I have the privilege to introduce this first in-person post-ASH review by Yale of hematology updates. So we have a really extensive agenda today covering all areas of hematology with really exciting speaker presentations. And we will devote 1 hour to each disease team, and the presentations will be about 15 to 20 minutes long for each speaker, and there will be time for questions. Sometimes for some sessions, there will be case presentations to discuss some of the challenging cases. So we do ask the audience to please participate and ask questions during the discussion part. So our first session will cover classical hematology topics, then we'll move on to lymphoma. So 2 sessions before 10 a.m. After that, we will take a refreshment break and go on with 2 more sessions, myeloma, leukemia, and 12:15, there will be lunch. And following that, at 1 p.m., we will have a distinct pleasure of hearing from Professor Stephanie Helena, our Chief of Hematology, who will deliver her speech on the biology of RNAs in myeloid malignancies. So a few housekeeping items. I'd like to mention that this activity is accredited for 6.25 CME credits and MOC credits. And while I personally dislike the idea of MOC, I am pleased to announce that this activity is accredited for it, and we offer it to you as part of your participation. But you must text during your presence here, during your attendance. Please go look at the blue instruction sheet for that. And after that, once you text, you will receive an email in a few business days to complete the questionnaire associated with this regarding CME registration. And if you have any questions, please go to the registration desk for any questions. For the purpose of CME compliance, I can state that all presentations have been reviewed and there are no relevant conflicts of interests. And please refer to the QR code on your blue instruction sheet at your tables. We are thankful to our organizers, the communications and the CME office of Yale. Thank you to Renee and Ann Stark and all of their teams. And we're grateful for the support from our grantors, AstraZeneca and Sobi, for their grant support. And please take time to visit the exhibitors today. So enjoy the day today. So we will go on and introduce our first session, which is classical hematology topic. And our presenters and discussants will be Drs. Eric Chang, Dr. Alex Pine, and Justine Ryu. And this session will be moderated by Dr. Kelsey Markin. Thank you.
They have presenter view just. Oh. Can we get presenter view? Yeah.
Good morning, everybody. Thank you so much for attending today. This year's ASH in classical hematology had some very exciting updates with novel therapeutics, which our first 2 presenters are going to highlight, and then we'll also be discussing some cancer-related thrombosis later on the session. Our first presenter is Dr. Eric Chang. Dr. Chang did his training at Yale, so welcome.
All right, good morning, everyone. Thanks for coming out. So I will start off our section on updates in classical hematology. The first abstract I'll be talking about is a report on the efficacy and safety of rilzabrutinib in patients with relapsed ITP. I have no disclosures. So ITP in adults can be characterized by a relapsing disease course and patients can be at increased risk for both bleeding and thrombosis, and also a reduced quality of life. It's difficult to achieve long-term remission with our primary treatment alone, and a durable response to second-line therapies is not guaranteed. So the management of relapsed and refractory ITP can be very challenging, especially for our patients who progress through multiple lines of treatment. ITP pathophysiology centers on the creation of autoantibodies, which bind to platelets and also suppress megakaryocyte function. And antibody-bound platelets are prematurely cleared by macrophages. So in 2022, there was a phase 1 and 2 trial that was conducted on 60 ITP patients who had failed prior therapies. And this study found that 40% of patients had a platelet response to rilzabrutinib, which was defined as a platelet count of 50 or more, and an increase in 20 or more over baseline. The highest response rate was found in patients who were receiving rilzabrutinib 400 milligrams twice daily, and the median time to platelet count of 50 or greater was 10.5 days. In this study, the authors didn't find an increased risk for infection, thrombosis, arrhythmia, hepatotoxicity, or bleeding. So the abstract that was presented at ASH this past year is the second part of this trial. And this was a continuation of a phase 1 and 2 trial. It was multi-center, open label, and ran for 24 weeks, and patients received 400 milligrams of rilzabrutinib twice daily based on the results of the first part of this study. Eligible adults had to have persistent or chronic ITP with 2 or more platelet counts under 30. They needed a prior response to either IVIG or steroids, and they needed to fail at least one other line of ITP therapy. Notably, concurrent stable doses of steroids or TPO-RAs was allowed on this study. The primary endpoints included safety as well as a durable response, which was defined as a platelet count of 50 or more on 8 or more of the last 12 weeks of rilzabrutinib use without the need for rescue medication. The secondary and exploratory endpoints included a change in the ITP bleeding scale score and health-related quality of life score. Baseline characteristics, there were 26 enrolled patients. The median age was 57. The median platelet count was 13. The median duration of ITP was 10.3 years, and median prior ITP therapies was 6. Prior therapies included steroids, TPO-RAs, immunosuppressants, including IVIG and cyclophosphamide, rituximab, splenectomy, and fostamatinib. Of the 26 patients that were enrolled, 15 completed treatment and 11 discontinued. 11 patients entered something called long-term extension, which was defined as platelet counts 50 or higher, or 30 and higher, with doubling from baseline in 4 or more of the last 8 weeks of treatment without the need for rescue medication. This is in comparison to 9 patients who were able to achieve a durable response. Of the 11 patients who discontinued, 5 were due to lack of response, 3 due to adverse events, 1 lack of response and combined adverse event, 1 patient was non-adherent, and 1 was erroneously enrolled. Adverse events were mainly grade 1 and 2, and they occurred in 16 or 62% of patients. These were largely GI symptoms and headaches, so diarrhea, headache, and nausea. There were no treatment-related grade 2 or higher bleeding, thrombotic events, no infections, serious adverse events, or deaths. And the only grade 3 adverse event that was observed was a rise in the CPK. During the study, 17 patients, or about 65%, received concurrent non-rescue steroid dosing and/or TPO-RAs, and 3 patients required rescue medication in the main treatment period. Median compliance for rilzabrutinib for patients with 24 weeks of treatment was 99%. So this graph shows that approximately 25% of patients achieved a platelet count of 50 or more by day 15 of rilzabrutinib. And in the 16 patients who did end up achieving platelet counts of 50 or higher, the median time to the first platelet count of 50 or more was 15 days. So this is pretty comparable to the results of the first part of the study, which showed a median time to achieve platelets 50 or higher was 10.5 days. This graph shows the trend of median platelet counts for all patients, including responders and patients who did not achieve a durable response, but remained in the study. And you can see that platelet counts steadily increased over time during the study. and they exceeded a platelet count threshold of 30 or more at day 57 and 50 or more at day 120. The mean number of weeks with platelet counts 50 or higher or 30 and higher and doubling from baseline was 9.3 weeks. This table goes through the ITP bleeding score, which basically grades the severity of bleeding symptoms at different anatomical sites. The mean baseline bleeding score was 0.27, and the mean change from baseline by week 25 was a difference or decrease of 0.07. The skin was the anatomical site with the highest proportion of patients with baseline score of 2. So this would be patients with 5 bruises or more with size greater than 2 centimeters and or diffuse petechiae. And in this study, all skin patients had a decrease in their bleeding score at the end of 25 weeks. This graph shows the improvement in quality of life scores for different domains, and the authors defined a clinically meaningful change as a change above 12 points. So the domains with the biggest changes were overall health-related quality of life. There was an improvement in 13 points, as well as women's reproductive health, where there was an improvement in 21 points. Women's reproductive health focused largely on menstrual symptoms, including menorrhagia, as well as the impact of ITP on the patient's receptiveness and attitudes towards pregnancy and childbearing. Fear and work were two kind of major categories that had minimal changes over the duration of the study. So in conclusion, it seems like in refractory and heavily pretreated ITP patients, rilzabrutinib can induce a durable response, so 35% in this study. There was a relatively rapid response, so the median time to platelet count of 50 or higher in responders was 15 days. Largely well tolerated, the adverse events were largely GI and headache, and there was some improvement in certain quality of life domains. Some considerations to take in mind when interpreting these results: it's a small sample, so 26 patients. There was a 42% discontinuation rate. And again, the majority of patients, so 65% of patients, were receiving concurrent steroids or TPO-RAs. The next abstract I'll be talking about is PATH-HHT, which looked at the role of pomalidomide and its impact on epistaxis in HHT patients, as well as its impact on quality of life. So HHT in adults affects 1 in 5,000. It's the second most common bleeding disorder worldwide, and it's characterized by AVM formation in mucosal surfaces, lungs, brain, and liver. Epistaxis is a common manifestation, and it can result in iron deficiency anemia, frequent healthcare evaluation, and overall reduced quality of life. And currently, there are no FDA-approved systemic therapies. HHT pathophysiology, so it results from the loss of function in the ENG, ACVRL1, and SMAD4 genes. And this loss of function results in perturbations in vascular remodeling, as well as blood vessel integrity. Thalidomide has been a drug of interest in HHT. It's an IMiD with anti-angiogenic effects, and it can downregulate VEGF and also improve vessel wall integrity. However, long-term dosing of thalidomide can be limited by neuropathy as well as GI toxicity. So pomalidomide appears to have a reduced long-term neuropathy risk compared to thalidomide, so it has emerged as a potential alternative agent of interest for treating HHT patients. So PATH-HHT was a double-blind, randomized, placebo-controlled, and multi-center trial. Patients were enrolled 2-to-1 to either receive pomalidomide 4 mg daily or placebo for 6 months. Patients needed to be adults with HHT defined by the Kurokawa criteria, and they needed an epistaxis severity score of 3 or higher, and anemia or an iron infusion requirement within the past 24 weeks of enrollment. The primary endpoint was a change in the epistaxis severity score, and secondary endpoints included change in daily self-reported epistaxis, the amount of IV iron or blood transfused, and a change in quality of life. So baseline characteristics: there were 144 enrolled patients, 95 to POM, 49 to control. Mean age was around 58.8 years. 48% of patients were female, and 11% of patients were non-white. The mean epistaxis severity score was 5, so 4.9 in the POM group, 5.2 in placebo. And it is important to note that enrollment was from 2019 to 2023, but an interim analysis did meet pre-specified thresholds for efficacy. So there was an early study closure. So about 8% in each group were terminated after 12 weeks. I've included a table of the epistaxis severity score here just to get a sense of what goes into calculating it. And it really involves on the frequency, duration of epistaxis, subjective severity, if patients need to seek medical evaluation, if they become anemic, and if they've ever needed a blood transfusion. So in the placebo group, 4% of patients discontinued, and in the POM group, 25% discontinued. 14% had an adverse event, 11% withdrew, and there was one unrelated death in that group. Adverse events, so mild, moderate neutropenia was seen in 45% of patients with POM, 10% in placebo. Constipation, diarrhea, 60% in POM, 37% in placebo. Rash, 36% POM, 10% placebo. And notably, VTE appeared to be pretty equivalent between both groups at 2%. This graph shows the decrease in the epistaxis severity score over time. So there was a mean decrease of 1.89 in the pomalidomide group and 0.89 in the placebo group. And it does look like towards the end of the study, the confidence intervals were non-overlapping. So there was a statistically significant difference by the end of this study. And this is a graph showing the change in the quality of life score. So a higher score means more limitations, so a lower score is better. There was a decrease of 2.6 mean score in the pomalidomide group and 1.2 in the placebo group. So it does look like potentially some improvement in quality of life as well. So conclusion, so pomalidomide use during the 6-month study period led to improved epistaxis severity score and potentially quality of life. The authors did not report an increased rate of neuropathy, and the main adverse events that were seen included mild, moderate neutropenia, rash, and GI symptoms, but the majority of patients were able to complete the study. The authors did also note they collected plasma studies before and after pomalidomide administration, so potentially in the future they could ID biomarkers to predict patients who will have a pomalidomide response. Some considerations when interpreting this study. So we do need data on extended use beyond 6 months. Is this a medication with lasting side effects, or does it really stop working when patients discontinue? And I would be interested to see if pomalidomide will help with other sites of AVM bleeding, such as GI, and if this could be a viable alternative to bevacizumab for a lot of our patients. The authors did report that one of their secondary endpoints was the frequency of IV iron and blood transfusions. As far as I could find, I don't think that was reported in the abstract. So I think this will also be an important piece of information to look for going forward. So that's all I have. Thank you so much for listening, and I will turn it over to Justine.
I'll introduce you. All right. Thanks a lot, Dr. Chang. So Dr. Ryu has done her training at Beth Israel Deaconess, and we're thrilled to have her discuss the next section of novel therapeutics. So thank you.
Good morning. My name is Justine. I also have no disclosures. So the first abstract that I'm going to be talking about is the use of lovo-cel gene therapy for sickle cell disease and its long-term follow-up. So sickle cell disease is a disease that's long been perceived as a disease with high morbidity and high mortality with limited therapeutic options. The backbone of sickle cell disease management includes hydroxyurea, which has been shown to improve survival, decrease pain, and decrease transfusion needs. There's also been other disease-modifying therapies that can reduce sickle cell pain crisis and increase hemoglobin levels, such as the one I've listed here. But none of these therapies completely eliminate the symptoms or halt disease progression. So looking at potentially curative therapies, allogeneic stem cell transplant have been used, but it has a lot of side effects with it. So high risks of graft versus host disease, graft rejections, and other causes of transplant-related mortality. And unfortunately, only a small proportion of patients even have matched donors to be eligible for stem cell transplants. Which brings me to the next generation of therapeutic options available for sickle cell patients, gene therapy. So these two listed, the ones I've listed here, lovo-cel and exa-cel, have been FDA approved in December of 2023 for the treatment of sickle cell disease. And the one I'm going to be talking about from this abstract is the lovo-cel gene therapy. So lovo-cel gene therapy is administered by autologous hepatic stem cell transplantation. These autologous hepatic stem cells are transduced with a lentiviral vector encoding the modified beta globin gene, which results in a production of anti-sickling hemoglobin A. And by utilizing the autologous transplantation, it eliminates two of the most important adverse side effects associated with allogenic stem cell transplants, GVHD and graft rejection. And it also provides a possible curative option while eliminating the need for a well-matched donor. The phase 1, 2, and phase 3 studies of lovo-cel are the largest clinical trials of gene therapy in sickle cell disease to date, and this abstract reports the efficacy and safety. So patients with sickle cell disease and recurrent severe vaso-occlusive events or history of overt stroke underwent plerixafor mobilization and apheresis. This is followed by myeloablative busulfan conditioning with lovo-cel infusion and engraftment. And then after 24 months of follow-up after the lovo-cel infusion, patients were enrolled into the long-term study. The analysis included 47 patients. The median number of vaso-occlusive events at baseline was 3.5 per year, with 3 severe events per year. And of the 34 patients who were able to be evaluated, 88% of the patients achieved complete resolution of all vaso-occlusive events during the 6 to 18 months post-infusion. And 94% of the patients achieved complete resolution of severe vaso-occlusive events. In terms of patient-reported outcomes, at 36 months, there were clinically meaningful improvements in pain intensity, pain interference, and fatigue in 57%, 64%, and 64% of the patients respectively. All patients maintained stable anti-sickling hemoglobin A levels from 6 months to the last follow-up, as far out as up to 60 months. In terms of the safety, a majority of the treatment emergent adverse events occurred within the 1 year post lovo-cel infusion and were known consequences of the conditioning with busulfan. And there were no causes of veno-occlusive liver disease, graft failure, or graft versus host disease. And there were no vector-related complications. There was one death that was thought to be due to the significant baseline sickle cell disease related cardiopulmonary disease, but it was not thought to be related to the study drug. So in conclusion, this one-time treatment with lovo-cel gene therapy resulted in sustained anti-sickling hemoglobin A production and near complete resolution of vaso-occlusive events and severe vaso-occlusive events up to 18 months post-treatment. The safety profile was consistent with underlying sickle cell disease and myeloablative conditioning. Patients reported sustained improvements in pain intensity, pain interference, and fatigue. And ongoing long-term follow-up will continue to provide efficacy, safety, and patient experience after the lovo-cel treatment. And I also just wanted to highlight that here at Yale, we also have an incredibly robust sickle cell program, and we do have gene therapy trial currently open under the efforts of Dr. Lakshmanan and Dr. Calhoun. And we have 2 additional trials that are underway to open, hopefully by late summer is what I've heard. Next, I'll be presenting a study looking at the use of recombinant ADAMTS13 in patients with congenital TTP. So as we're familiar, TTP is a thrombotic microangiopathy caused by a severely reduced activity of the von Willebrand factor cleaving protease called ADAMTS13. The deficiency of ADAMTS13 can manifest in 2 forms. So the one that we're much more familiar with is the acquired form known as immune-mediated or idiopathic TTP. And then much more rarely, there is a congenital form which arises from an ADAMTS13 mutation. And this trial, or this abstract specifically focused on this congenital TTP. patient population. So congenital TTP is an ultra-rare, life-threatening thrombotic microangiopathy that's caused by inherited deficiency of the enzyme ADAMTS13. Plasma has been the primary source of exogenous ADAMTS13 for the treatment and prophylaxis in patients with congenital TTP. To assess the efficacy and safety of recombinant ADAMTS13 for the treatment of acute TTP, this abstract looked at long-term prophylaxis and treatment in patients with congenital TTP. So this was a phase 3 prospective randomized open label multi-center crossover study. Patients were randomized at 1-to-1 at enrollment to receive prophylaxis with either the recombinant ADAMTS13 or standard of care. And the standard of care was determined by the treating physician. Patients in the phase 3B continuation study received open label recombinant ADAMTS13 treatment. And in both studies, patients could receive treatment on demand for acute TTP events. The study enrolled 48 patients in the prophylactic cohort and 5 patients in the on-demand cohort. And patients included were aged between 0 to 70 at screening. And at the end of the data cutoff, there were 8 acute TTP events that were reported in 7 patients. And interestingly, none of the events occurred while the patients were receiving the recombinant ADAMTS13 for prophylaxis. 3 events occurred in the patients being treated with the on-demand recombinant ADAMTS13, and the events resolved without requiring administration of any other treatment containing ADAMTS13. 5 events occurred in the patients being treated with the standard of care, with 1 event occurring while the patient was receiving prophylaxis with standard of care treatment. Over the first 3 treatment days, the mean platelet count increased more than 5-fold. So it increased more in the recombinant ADAMTS13 arm compared to the standard of care. And in the post-infusion ADAMTS13 activity was also much higher in the recombinant ADAMTS13 compared to the standard of care arm. There were no serious treatment emergent adverse events observed on either arm. And importantly, there were no neutralizing antibodies against ADAMTS13 antibodies related to the recombinant ADAMTS13. So in conclusion, all 3 acute TTP events treated with recombinant ADAMTS13 resolved promptly with the treatment protocol with recombinant ADAMTS13. The resolution of acute TTP events and an improvement in platelet counts in patients with congenital TTP following treatment with recombinant ADAMTS13 seemed to be closely related to the higher ADAMTS13 activity level that was able to be achieved with recombinant ADAMTS13. There were no serious adverse events related to the recombinant ADAMTS13 and no neutralizing antibodies against ADAMTS13. So the recombinant ADAMTS13 did receive FDA approval in November of 2023 for the treatment of congenital TTP. What might be a little bit more exciting for us adult hematologists is that there's a phase 2 study evaluating the safety and efficacy of the recombinant ADAMTS13 among patients with immune TTP, which showed that recombinant ADAMTS13 plus PEX or plasmapheresis showed favorable tolerability and increased ADAMTS13 exposure. So there are currently clinical trials utilizing the recombinant ADAMTS13 in acquired TTP patients underway. In the TTP world, caplacizumab has been the most recent new treatment available for these TTP patients, but maybe several years down the road, we'll be seeing recombinant ADAMTS13 play a role in TTP as well. Okay, thank you.
All right, thank you so much, Dr. Lee. That was an amazing discussion. Okay, our next speaker will be Dr. Pine. We're going to switch gears and talk about thrombosis.
Thank you. Thank you. Thank you. Good morning, everybody. I'm Alex Pine. There we go. Yes, we're going to switch gears a little bit, and this brilliant conversations and presentations. We're going to do some nerding out. Let's see how it's moving. Okay, yeah, no disclosures for me as well. So I'm going to review a couple of abstracts sort of under the umbrella of cancer-associated venous thrombosis. Actually, both of them from Memorial Sloan Kettering Center group, where they actually studied this in a kind of very substantial way. And specifically, we're going to discuss a couple of models and a couple of ways to get at estimation of the risk of cancer-associated venous thrombosis, which as we all know, is a source of significant morbidity and mortality in cancer patients. So there are some models currently used that are static, which means that the risk is determined at one time during the disease. And one of the most highly validated models is Corona score. Now, these models actually, there's a couple others, but all these models have or suffer from very subpar performance, and sort of just to kind of get you some ideas of how really bad it is. So, CIS statistics is one of the measures that are commonly used to assess how well the model performs in predicting who would, predicting of the event of interest. In this case, for specifically, it will be cancer-associated thrombosis. So in this statistic, specifically for Corona score, is less than 0.7. So just to put it in context, 0.5 is a towing cost. So that's not very good. And just to drive it home, if you kind of look into specific values, characteristics of this model, something called recall, for instance, which is a proportion of true positives identified correctly. So that's a half. That's a half in half cases. And precision of the model, which is proportion of true positive among all positives, is 9%. So what it means, essentially, for this particular model, that 90% of people who predicted to have an event did not. So that's pretty bad. And so we can't really use this. We can't really use it. And I haven't seen too many people actually using this for many reasons, but also for this reason. This model is to predict thrombosis. And so the group in Memorial Sloan Kettering, they've been at it for a very long time, and they came up with sorts of different workarounds and kind of interesting ideas. And I think these two that were presented last year caught my eye. I think I wanted to kind of go over with you. So one of them is something called dynamic modeling. So the idea here is that dynamic modeling would allow a model to use all accumulated data, not just one event of data, not just one set of data, but all accumulating data to the event, which could be very interesting because the recent data, the recent meaning recent to the cancer diagnosis, for instance, would be more valuable than the data that, say, was acquired 6 months ago. So, but then what's also important is that the trend of this data could also be a predictor itself. And so if we use, for instance, here, you can see that the last data, so all the data points here, here, and here are all the same. So if you use that one data, the models will be predict the same outcome, but the trends are different. And so those trends can reflect a different biology. And that would be very important to account for that in the model. And so this is basically a pictorial representation of this. So all the circles are different tests, whatever clinical tests people do. And so you can rely on all of them to put into your model to use to determine the risk of venous thromboembolism. You can use data from last month. You can use data from 3 months, and so on. Maybe every day, every week. It's up to the model. But the idea is that to use all the data to derive the risk. So they use quite a number of patients, more than 12,000. They identified different set of predictors. So age, cancer type, time from cancer diagnosis, chemotherapy. Of course, they use chemotherapy, aging class, all sorts of lab values. And also they use something called missing value. We don't have to really focus on that, but it's kind of interesting aspect. And they use this 1 unit, time unit was 1 month. So it could be 1 week, could be 1 day. They use 1 month. They use 2 different methods. We're not going to go over, of course, over them, but basically it's all the logistic regression where you predict the outcome from all this data. There's a Bayesian dynamic multivariate modeling when it's got a complicated model where each parameter depends on each other parameter. But essentially what they showed that in logistic regression as well as Bayesian modeling with there's now 1 month lead time, the statistics is 0.75, which remember I told you that 0.6.5 was towing cost. So 0.7 and 0.77, it's actually getting to the level where it's potentially could be acceptable to use in clinic, meaning that the quality of prediction, the performance of the model will actually give us some valuable information. So in a 3-month lead time, sort of the numbers were very similar. So then they also identified the features of interest from the logistic regression. So it were the most important was actually use of alkylating agents. Different cancers came up as a predictive parameters: breast cancer, high-grade glioma, albumin, use of platinum agents, for instance, melanoma, and so on. So this model, dynamic model, it improved performance over Karana score. I would say quite substantially. So going from less than 0.6 statistics to almost 0.8, that's a very reasonable improvement. Identified additional features that are important in predicting the cancer-associated thrombosis. And it was interesting, they proposed an interesting idea here that this mechanism, this model could be actually built in the back end of EMR, where essentially a patient would be assessed in real time, or rather risk of the cancer-associated thrombosis for a particular patient would be assessed in real time, and then EMR will flag this patient should take blood thinners, anticoagulation, but at a certain time, not all the time, for instance. So that's kind of was an idea. Okay, so moving on to the next model, which in my opinion, even more interesting. So here what they used is they relied on liquid biopsies, especially some genomic information gleaned from liquid biopsies. So liquid biopsy essentially is becoming a more and more widely used tool in assessing the prognostic probability tool in assessing cancers because it gives interesting information about targets, therapeutic targets, prognostic values. So they thought, the group thought that it could work in assessing the risk of cancer-associated thrombosis. Why? Well, so circulating tumor DNA, because tumors will secrete some DNA into circulation, and that's the whole basis of liquid biopsy, is thrombogenic. So when people actually took the thrombi from cancer patients, dissected that, they found cancer DNA, tumor DNA inside the thrombi, which suggests that potentially those pieces of DNA, cancer DNA, tumor DNA, were basically serve as nidus for thrombosis. And cancer tumor DNA serves as a biomarker of disease burden and survival. So they wanted to understand if this tumor DNA, circulating tumor DNA, is associated with thrombosis, and also develop a model of the thrombosis, basically used features that come from circulating DNA. So they have 3 cohorts, but we'll talk about one cohort that they use their own cohort, just for clarity of this discussion. And so what they showed that indeed the presence of cancer DNA, the circulating tumor DNA is associated with thrombosis. So here's a bit. So the lower, the red circle, the red curve is a curve that with DNA positive patients. So indeed, the tumor DNA was risk factor. And you kind of think, but that's probably true, right? Because biology of cancer, as for which tumor DNA is a surrogate, probably is what defines the thrombogenicity of the cancer. Then they also said that this risk is present in dose-dependent matter. If there's a more DNA, there's a higher risk. It also held up across different cancers, specifically non-small cancer, pancreatic cancer, melanoma, prostate cancer, and others. It also, the risk, this presence of circulating tumor DNA held up through different genotypes, and some of them probably fairly expected. KRAS, for instance, or HER2, we kind of know that those are probably tumors that express those genes, or have mutations rather in those genes, have higher risk of thrombogenicity. Then they actually ran this feature of a circulating DNA against other features. So for instance, Corona score, and it actually was more predictive than Corona score already. Just looking at this graph with a, and then they did also analysis of how this model, so liquid biopsy model, performs against Corona score. Remember Corona score? That was almost coin flip, as bad as it was. So so a liquid biopsy model included essentially all the values that you can glean from liquid biopsies. So it's a concentration of tumor circulating DNA, the variable allele frequency, genomic content, so which genes were affected. And you can see here, so just kind of, so you understand the graph. So the black line here, that's a Corona score. So the line that is closer to 1, to the corner with 1, that's better. So so the this blue line and the red line, they are closer to the corner where 1 is. That is better performance, and a significantly better performance. So Corona score C statistics is 0.665, kind of standard, and a liquid biopsy here is a 0.76. So it's much better performance. And they also said, well, if somebody was taking anticoagulants, blood thinners for something else like atrial fibrillation, were they actually a lower risk at developing thrombosis? And yes, they were. Even in patients, so the patients with circulating DNA who were taking blood thinners were at lower risk, which kind of makes sense. So to conclude, circulating tumor DNA is independent biomarker for cancer-associated venous thrombosis. So the model trained on liquid biopsy outperformed Corona score. And so for me, here's an interesting outcome of this, specifically of this second model. So liquid biopsies becoming more and more acceptable and more used for prognostic and treatment decisions. And so what I'm thinking is that this is going to become probably a tool in near future to calculate the risk for thrombosis. It's much easier to use once you have the data than this dynamic modeling and models with a lot of different parameters that busy clinicians have to put together in some kind of a calculator. Here, you do liquid biopsies, clinicians do liquid biopsies on patients. You already have the data. It's essentially almost free for us, right? Because liquid biopsy has already been done. I think this is where it's going. Thank you.
Thank you. That's your passion is. Fantastic. We're gonna open up for questions. So if anyone has a question, if you could please alert me so I can come over to you. Yeah, motion.
I have a question for Dr. Chan regarding the rilzabrutinib, the BTK inhibitor. I had a question about what I noted is that the time to platelet response for for this heavily relapsed refractory ITP patients was about 10 days, which seems substantially shorter than what you would expect for other cell depleting therapies, right? CD20 antibodies may take 4 to 6 weeks. So I'm wondering whether there is a trend to consider incorporating BTK inhibitors earlier on in the course of the disease. So that's one. And the second question I thought, in terms of, so would you consider using it in the earlier line, and how would you sequence with the current availability of agents?
Thank you. So I think the BTK, it's a covalent inhibitor, so it's multifactorial in that it's not only inhibiting the B cell autoantibody production, but it's also impacting the SYK pathway mediated phagocytosis of platelets. So it's multifactorial. So I wonder if that might bring about the faster response compared to like rituximab, which would be working on the antibody production alone. In terms of sequencing, so my understanding is, like, for example, fostamatinib, the response rate is like somewhere in the 20 to 40% neighborhood, which is relatively comparable to rilzabrutinib, but I think the TPO-RAs perform better still. So I think that still stands as like my preferred option in the second line treatment. But I do think one of the merits of the rilzabrutinib in the study is that these were like really heavily pretreated patients, like 6 median lines of therapy. There were like 50% of patients who had splenectomy. So I do think there's a lot of therapeutic opportunity for this, and patients continue to tolerate it well. And it's a reasonable, easy pill to take. I think it would be very, it's definitely an option you could consider using earlier.
And may I just add, could you also comment on the interaction with GP1B with first generation BTKs, and how is this different, and how much less bleeding risk associated with it?
Yeah, my understanding is that it's much more targeted. So the authors had observed, and there's a lower theoretical concern for some of the other kind of off-target side effects like arrhythmia. And in this study, they didn't really see any increased risk for bleeding or thrombotic events. So I think it's very targeted way of combining.
Those are great questions. Anybody else have any questions that I can walk the microphone over to?
I just want to thank Alex for simplifying the statistics for somebody who can't figure it out. But I think the question I had is in the second study, did they, or do they have, they should have access, I would think, to specimens to actually do some germline testing for a simple battery of tests for inherited coagulation abnormalities that might predispose. Was that looked at, or is that something that they mentioned as a future possibility?
Yeah, thank you. I think that's a great question. They did not explain this, did not even was not brought up in their conversations, and either in their presentation. But I think it's something that probably should be addressed in some kind of a sub-analysis. Makes sense.
It's been looked at just independently of the circulating tumor cells, in various populations, but I don't think in any real systematic way. But if you could be using that the genomic information from the cancer cells, you'd like to know the genomic information of the host.
I absolutely agree. That needs to be rolled out.
Question?
Dr. Klein, Mike Farrell, thanks for a fantastic presentation. Question I have is, could it be that the circulating tumor DNA is more of a reflection of tumor burden as opposed to being a nidus for actual thrombosis?
Excellent. Very, very good question. So yes, that's actually is a reflection of tumor burden for sure. And I didn't show that, but actually in that presentation and publication earlier, it's in Nature Review 2022, they actually looked at it. So what they did, they extracted the burden of disease from PET scans, and then they essentially correlated that the area with the volume with circulating tumor DNA, and it was very nicely correlating. Of course, there was some exceptions to the rule, but they were correlating. So it is the burden. So there's a correlation with burden of disease. What they also showed when they sort of adjusted the model for burden of disease, it still held up. And it held up actually with the same or very close C statistics. I think it was like in low 47. Yeah.
Excellent.
They actually looked at.
Thank you.
Thanks, everyone. I had a question for Dr. Reed regarding the lovo-cel gene therapy study for sickle cell disease. I remember from like the decades of literature on gene therapy for like hemophilias, for instance. I think the challenges there were the durability of the product. So I was wondering whether there's any experience in how much, or at least do we have some preclinical ideas about this particular product in terms of durability over the decades, or what's the durability of it?
Yeah, so I think there was data on 20 to 30 patients here that showed it does, the anti-sickling hemoglobin A does stay high and durable for up to at least 60 months in the longest patient with the longest follow-up. So it does seem very durable.
I'll ask another question from Dr. Reed. For gene therapy, has there been thoughts about, you would raise the question of myelodysplastic syndrome, and I think this has come up maybe at ASH or other meetings about checking for CHIP, younger patient better. Just wanted to hear your thoughts about or something.
Yeah, there's always that risk of maybe lentiviral induced secondary malignancy, at least in this follow-up for the 40 patients or so that they've seen. We did not see any lentiviral related adverse events, including secondary malignancies, but yes, that's always something that we think about. And I also wonder, there's now different lines of gene therapy. So this was lentiviral induced. Now there's like CRISPR based gene therapy. So I'm not sure if we're going to see different risks associated with the different types of gene therapies going forward.
So great presentations, you guys. I have a question for Dr. Klein and Dr. Chang, if I could. So, Alex, is there any evidence that circulating DNA activates the innate immune system? And Eric, in the pomalidomide treated individuals who had adverse events, was there an opportunity to reduce the dose of pomalidomide and continue on the study?
Thank you, Ingo. So I think that's a very good question. I would imagine that it actually probably causes some activation, and if you just think about that, the circulating DNA could potentially activate the traps, neutrophil traps, which is probably at least one mechanism proposed of how this happens. So I would imagine that actually it activates not only, I would not necessarily think like it's in general, but specifically neutrophil extracellular traps, and then the cascade that we all kind of learn through vasculopathy and then endotheliopathy. Of course, I would imagine so. They haven't talked about this in particular, but I think from what we kind of all read and learn, I think probably very, very possible.
And I believe dose reduction was allowed in the study, but I don't think they reported on how many patients who had the adverse events ended up dropping and what the outcomes were afterwards.
We had another question from the audience. Move over. And probably a question a number of people are thinking about for Dr. Yo's cost and any information on his cost analysis. And I think the question was also specifically if, how it might compare with reduction in, future hospitalizations or reduced, vaso-occlusive events.
Yeah, cost is high for all the gene therapies. And they say the cost is because of all the hospitalizations, of potential therapeutic, other therapies that they're preventing or other morbidities that they're preventing. In terms of the cost effective analysis, I believe Dr. Gosha has done one in sickle cell disease and gene therapy related, to say that it probably cost is still too high for what it is supposed to prevent. Yes, but yes, cost is an issue.
Okay. So I'm gonna ask a question of Dr. Chen, but then anyone else have a question? Okay. So I noticed for the rilzabrutinib study that women's health was a secondary outcome, which I think was really important. Have other, maybe TPO agonists, have other drugs used, maybe something specifically like menstrual bleeding as an outcome? I think that's just really important for how we think about future drug approvals in ATP or bleeding disorders in general.
Yeah, definitely. I think the ITP bleeding score in the health-related quality, it is, from what I was reviewing in other ITP trials, it's a common metric that's been used, but I'm not aware actually of, and other alternative agents if they've looked at this. So off the top of my head, I'm not sure, but definitely I think that's important consideration. I think, and especially for folks who treat a lot of ITP patients, it's a lot of the time the disease manifests in ways that's just beyond the platelet count. Certainly I think fatigue is a huge issue for a lot of these ITP patients. So I think just looking beyond the number and kind of impact on psychosocial elements appears also really important.
Thanks, everyone. Really great discussions and amazing abstract selected for this presentation and great discussion. And this is a very punctual group, so I appreciate everybody being cognizant of respectful of everyone's time. So we will move on to the lymphoma session next, and this session will be moderated by Dr. Huntington, and our discussants and presenters are Dr. Shawn Kothari and Dr. Tarshin Zaghi. So thank you.
Morning, everyone. It's nice to see so many familiar faces this morning. I have the distinct privilege of introducing two of my close colleagues to give updates on lymphoma. The first will be Dr. Shawn Kothari, who received his medical degree at Gujarat University in internal medicine training in SUNY Upstate. He really enjoyed the winters of upstate New York and stayed at Buffalo for fellowship, really productive fellowship there, both in the clinic and in the research, the bench. We recruited him at Yale. He's been here for several years. His clinical focus is in aggressive lymphomas. And he still has a footprint in the lab and really interfaces closely with laboratory colleagues. He'll be focused on B-cell lymphomas, and we'll follow that up with Hodgkin lymphoma and T-cell lymphomas with Dr. Sethi. So welcome, Dr. Gathari.
Good morning, everyone. So I'm going to focus on B-cell lymphomas, no relevant disclosures. I'll first cover mantle cell lymphoma, followed by DLBCL, then follicular lymphoma, and CLL. So in mantle cell lymphoma, there are quite a few, I think, important updates. The first being abstract number 738, which is a phase 2 trial of zanubrutinib with obinutuzumab with venetoclax, termed BOVEN, in treatment-naive TP53 mutant mantle cell lymphoma. So you can see on the left the curves of patients with TP53 mutation with standard of care approaches, mainly with rituximab followed by immunochemotherapy. The outcomes are fairly poor. The PFS essentially is in months. So clearly there is need for improving this, especially now in the era of more targeted therapies. And this was particularly done by the MSK-CC group, where there was combination developed of zanubrutinib with obinutuzumab and venetoclax. So zanubrutinib, obinutuzumab started on day 1, and followed by venetoclax starting cycle number 3 with ramp-up dosing. All patients got a minimum of 24 cycles, followed by MRD-driven approach to limit treatment duration. So patients who were in CR, they eventually stopped treatment. And if they were not in CR or they had measurable disease, then they would continue zanubrutinib and venetoclax while stopping the obinutuzumab. The inclusion criteria was fairly standard. There's something to note here is that any TP53 mutation was allowed on this trial. So we don't necessarily have a lot of data on exactly how pathogenic that particular mutation is. And I'm sure it will become more clear in the manuscript, but it was not that evident in the abstract itself. So the results are fairly encouraging, of course, barring that specific point that I mentioned about TP53 mutation. One thing that I noticed in this abstract, which is very good, it's like a poor man's way of kind of knowing whether the patient has TP53 mutation or not, is that just by IHC, 90% of these patients who had a mutation had TP53 overexpression. And it was defined as more than 30% IHC expression. At Yale, we have incorporated this marker in all mantle cell lymphomas going forward. So I think that's a crucial piece of information. So for this particular trial, the PFS endpoint was met. As you can see, the 2-year PFS is 72%. Median PFS was not reached at median follow-up of 23 months. And overall survival at 2 years was 75%. Median OS was not reached. The second trial is in relapsed refractory space in mantle cell lymphoma called the Simpatico trial, randomized phase 3 trial of ibrutinib plus venetoclax versus ibrutinib plus placebo for 24 months, followed by maintenance. Around 267 patients were enrolled on this trial with ECOG performance status of 0 to 2. They were randomized. And then thereafter, as I said, all the patients got ibrutinib maintenance. The PFS was met for this trial as well. Importantly, no new toxicities were observed, but of course, with the combination, grade 3 cytopenias were very common, and it led to quite a bit of dose reductions, especially in venetoclax, but also in the cases of thrombocytopenia with ibrutinib as well. There was no OS benefit, and I'm not showing the curve here, but there was some numerical benefit and potentially a trend, which may become more clear as the data matures even more. So this was in the relapsed refractory space. The other relapsed refractory trial, which is also very important to discuss, is Bruin trial of monotherapy with pirtobrutinib, which is a non-covalent BTK inhibitor. It is a phase 1/2 trial. This particular trial incorporated all non-Hodgkin lymphomas, but specifically right now talking about the mantle cell lymphoma cohort, which enrolled 166 patients. As we know, in mantle cell lymphoma, we see this in clinic all the time, that outcomes are extremely poor after patients progress on covalent BTK inhibitors. So there is quite a bit of an unmet need there. And the important feature of pirtobrutinib and now the newer BTK inhibitors and degraders that are being developed is that it is agnostic to a particular mutation, which is quite common in covalent BTK inhibitors called C481S mutation. Not only that, there are better kinetics, PK kinetics, as you can see here, with much better half-life of around 20 to 24 hours. And also the binding with the BTK is in such a way with pirtobrutinib that it essentially leads to an inactive conformation for much longer than the covalent BTK inhibitor does. So all of that put together, the pirtobrutinib is a very important drug for non-Hodgkin lymphomas, especially mantle cell lymphoma and CLL. And with this data, which I'm about to show, pirtobrutinib was approved by the FDA in relapsed refractory space for more than 2 lines of therapy, and one of them including covalent BTK inhibitors. So out of the 166 patients, 152 had received prior covalent BTK inhibitor, 14 patients were naive to the covalent BTK inhibitors, and these are the curves here. So overall response rate of almost 50%, median duration of response 22 months, median PFS of 5.6 months, and median OS of 23.5 months, which is quite impressive, especially after progressing on covalent BTK inhibitors. So now moving on to aggressive large B-cell lymphomas. The first thing I kind of wanted to just go over a brief landscape of bispecific antibodies in lymphomas, and that we'll also talk about follicular lymphoma here as well. So there are 4 clinically available bispecific antibodies at this time. All of them are CD20, CD3 bispecifics, mosunetuzumab, glofitamab, odronextamab, and epcoritamab. There are some variations in how the immunoglobulin fragment formats, but the more important thing is the mosunetuzumab is approved for follicular lymphoma, 3-line and beyond, and it is currently intravenous, but subcutaneous formulations are also being studied. Glofitamab is approved in DLBCL, NOS, and transformed follicular lymphoma in to DLBCL, again 3-line plus. It is also intravenous, with one thing to note that it is with obinutuzumab pre-treatment to reduce the chances of CRS. Third one, odronextamab. The BLA was submitted to the FDA, but it is currently not approved. But the BLA has been submitted for both the diseases, so follicular lymphoma and DLBCL, and this is also intravenous. Epcoritamab is approved in DLBCL. So basically for DLBCL, we have epcoritamab and glofitamab for the same exact indication as glofitamab, and epcoritamab is subcutaneous. So the first trial that I wanted to discuss here is abstract number 433, which is an extended follow-up of phase 2 study of glofitamab in relapsed refractory large B-cell lymphoma with median follow-up of 32 months. You can see that it's a fixed duration treatment of up to 12 cycles. That's a very important thing to note here. The CRS mitigation was achieved with obinutuzumab pre-treatment only at cycle number 1. So on day 1, you would get obinutuzumab. Day 8 is 2.5 milligrams, followed by day 15, 10 milligrams, and cycle 2, day 1 of 30 milligrams, and that would be the dose for the rest of the cycles. The inclusion criteria is fairly standard, more than 2-line prior therapies, including CD20 antibody and anthracycline-containing regimens. I think it's important to note here that 51 patients or 33% of patients had received CAR T-cell therapy, and 85% of patients were refractory to prior line of therapy. So these were heavily pretreated and likely refractory patients overall, which we see in clinic all the time. So the CR rates and duration of CR in patients with prior CAR T-cell therapy was consistent with overall population. That was very encouraging to see. So this is the part which was newly presented at ASH 2023. You can see the gray curves are the patients who had received prior CAR T, and the black curve is all the patients on this trial. So which the CAR T line tracks fairly closely to all patients, which is quite encouraging to see that even if the patients have received CAR T in the past, it's likely that glofitamab is going to work. High proportion of patients with CR at cycle 3 remain progression-free. So we consider honestly for all bispecifics, but in this case, particularly for glofitamab, that if you are in CR by 3 cycles, which is 3 months, it's very likely that this drug is going to work. And we even see some potential tail developing, and then it's quite possible that around 40% of patients are cured as well. But of course, we'll have to wait for the data to mature. And I would personally, given how bad the curves look for patients who don't go into complete remission, I would be prepping for the next line of therapy, likely a clinical trial, if not in CR in 3 months of initiating glofitamab. Next is abstract number 68. So the next 2 abstracts are just a few housekeeping things, something that we do every day, but just a few reminders. So this is a retrospective study of treatment intensity in elderly patients more than or equal to 70 years of age with DLBCL in first line. They included around 434 patients. The model of this abstract here is that patients in the age group of 70 to 79, clinically, we tend to reduce the dose quite a bit because, of course, there is worry about toxicity or maybe they have some other comorbidities. But what this data really shows is that if you reduce the dose of R-CHOP, the outcomes are worse. The yellow curve is the reduced R-CHOP, the blue curve is standard R-CHOP. So I thought this was kind of important as a reminder in general that we should have a higher threshold to reduce the dose in this age group. And interestingly, this difference was not observed in patients more than 8 years of age, which is the most classical guideline, right? That we would reduce the dose to mini R-CHOP in patients who are more than or equal to 8 years of age. So I think this serves as a very important reminder to be careful about that age group of 70 to 79 years. And another abstract that we participated in, and Dr. Aisoufi was one of the co-investigators, is abstract number 312. It's a retrospective real-world study of loncastuximab, which is a CD19 antibody drug conjugate in relapsed refractory large B-cell lymphoma. And again, not going over too much detail, but they basically passed out the data to see in real world what kind of patients had the best response to lonca. Because otherwise it's not really looking great, right? So if you look at the red curve, median PFS is 2.1 months, median overall survival is 4.6 months. But if you look at the subgroups, non-GCB patients responded the best. So which I found very interesting. I mean, there is no real biological correlate to it, but something that I will keep in mind going forward, because in DLBCL, we have so many drugs now in relapsed refractory setting available that I think we have to have some way of prioritizing some regimens over the other. And I think such nuggets are very helpful in doing that. So they found that non-bulky disease and not refractory prior line of therapy is helpful as well. But although that's probably true for all agents, but I think the more important thing is the non-GCB part. Third disease that I'll cover is follicular lymphoma. And again, kind of the same theme of bispecific antibodies making a splash. This one being mosunetuzumab, given similarly in step-up dosing to reduce the chances of CRS. Day 1 milligram, day 8, 2 milligram, day 15, 60 milligrams, followed by dropping to 30 milligrams cycle 3 onwards. And you can see that 69%, almost 2/3 of patients were refractory to last prior therapy, followed by 80% of patients also being refractory to any prior anti-CD20 therapy. And more importantly, half of the patients were POD24. So they had progression within the first 2 years. So they were quite, overall aggressive diseases. The 3-year overall survival is 82%. Now, these curves are not that difficult to see in follicular lymphoma, but I think with that patient characteristic population, I think it's still pretty impressive. And I'm sure Dr. Huntington will talk about it later on. The goal, even with DLBCL and follicular lymphoma, is to move these bispecifics up in the line of therapies for various benefits for further, solidifying the CR rate. Next is not really an ASH 2023 update, but it's like this month update, which I thought was important to add as we practice, is a study published in July 2023 in JCO called the trial Rosewood trial, which is a randomized phase 2 trial of zanubrutinib plus obinutuzumab versus obinutuzumab alone. Now, this particular combination of zanubrutinib with obinutuzumab is approved by the FDA this month for 3 lines plus in relapsed refractory follicular lymphoma. Of course, the more agents we have, which is it's becoming a very crowded space, I think we need to overall do better in designing trials so that we know how to layer and sequence these therapies. But it's quite impressive. The blue curves being zanubrutinib obinutuzumab. The ORR is 69% versus 46% in obinutuzumab. So clearly there is some lifting done by zanubrutinib as well. Biologically, it's not entirely clear, but impressive enough that FDA approved this combination. So this is what we have for relapsed refractory follicular lymphoma. In second line, we have chemo plus rituximab or obinutuzumab, lenalidomide with rituximab or obinutuzumab, or depending on if not very bulky, but otherwise still needs treatment. Even CD20 antibodies itself are probably good enough, followed by maintenance. The space 3-line and beyond is crowded, and that's great for our patients and us. Mosunetuzumab, Exa-cel, and Tisacel, tazemetostat, zanubrutinib plus obinutuzumab, and of course, autologous and allogeneic stem cell transplants. And I'm sure CAR T-cell therapy will be covered in much more detail in the immunotherapy section. But just to kind of go over some differences, right? So CAR T-cell therapy, the biggest benefit, I think, is that it's one and done. And the chances that the patient will be off any treatment is much longer with CAR T-cell therapy. But there is a higher chance of CRS, a higher percentage of ICANS. It requires manufacturing, so it takes some time to get it into the patient. Versus bispecifics is off the shelf. Granted that some of bispecifics still need inpatient admission for observation initially, but I think we are slowly figuring that out as well, especially with glofitamab and mosunetuzumab. There is definitely significantly lower chance of CRS, a grade 3 CRS. I think in all of these trials, almost 80–90% of patients had CRS, but the grade 3 was lower, significantly lower in comparison to CAR T-cell therapy. But the biggest downside is that it needs longer treatment. We don't necessarily know when we should stop bispecific antibodies. The fourth disease that I wanted to cover is CLL/SLL. The first study is abstract number 325 called the FLAIR trial. Is a phase 3 study of ibrutinib plus venetoclax with MRD-directed duration of treatment. It, I think, is very novel. So the way they have designed the MRD is, and the stopping rules are here. So if the patient is on the red curve where they go into MRD negativity at 1 year, then they would get this combination for 1+1, which is 2 years. If they go into MRD negativity at 2 years, then they would get 2+2, which is 4 years. And the maximum that the patients would get this combination is up to 6 years. The idea is that if it takes longer for you to go into MRD, then you would get more of that. And you can see the PFS and OS curves, which are very impressive, although this is CLL, so curves definitely look better in comparison to other diseases. Important to note that the Richter's transformation patients and patients with more or equal to 20% of deletion 17p were excluded. Clearly those are high-risk populations which were not included. And the comparator is FCR, which in itself is definitely not the standard of care in the US anymore. And this is a European trial, by the way. And I think the field is slowly moving towards this combination of BCL2 inhibitors and BTK inhibitors in the frontline in CLL. So I think this is an important study, especially the stopping rules being very innovative. The next study I wanted to focus on is abstract number 327, which is a phase 1/2 study of sonrotoclax by BeiGene plus zanubrutinib in treatment-naive CLL. You can see that this was, of course, a dose-finding study followed by dose expansion in 2 different doses, 320 milligrams and 160 milligrams. Sonrotoclax, just like venetoclax, is also a BH3 mimetic, but with much more high potency in comparison to venetoclax. And this particular combination saw ORR of 100%. And the phase 3 trial comparing with venetoclax and ibrutinib is going to be open at Yale very soon in like a week or so. So this would be an important study for our CLL patients in frontline. Next is abstract number 202, extended follow-up of Alpine. This is a randomized phase 3 study of zanubrutinib versus ibrutinib in relapsed refractory CLL. I think Alpine, we talk about it every year because there's like few more months of follow-up data that comes along. And this basically just shows that zanubrutinib continues to look better than ibrutinib. One thing I found interesting is that zanubrutinib saw significantly more COVID-19 related grade 3 infections, but a much better cardiac profile. And lastly, I wanted to cover abstract number 325, the Bruin trial. Again, I covered that in mantle cell lymphoma, but this particular time, I'm going to focus on the CLL cohort. A number of patients were 317 with median follow-up of 30 months. And just like with mantle cell lymphoma, this pirtobrutinib is also approved for CLL, approved in December of 2023 for 3 lines plus. They should have relapsed after covalent BTK and BCL2 inhibitor both. Sizable percentage of grade 3 or more infections were observed. So that's something to keep in mind, that it's not a walk in the park, but it's definitely a very important tool that we have now available to circumvent resistance to covalent BTK inhibition. Median PFS of 16 months and median overall survival was not reached. Just to summarize, so in mantle cell lymphomas, zanubrutinib plus OB plus ven is promising for treatment-naive TP53 mutant mantle cell. More data is needed, and I think at Yale we have upfront clinical trials. So if there are such patients, I think it's still best, I think, to enroll patients on trials. Simpatico shows improved PFS with ibrutinib plus venetoclax versus ibrutinib alone after first line. Pirtobrutinib is promising in patients with post-covalent BTK inhibitors and is now FDA approved for mantle cell lymphoma. And something I didn't cover here, but is important to note, is that there was a retrospective study which basically showed that it's better to use BR followed by BTK inhibitors sequentially rather than combining them together, just like it was done in SHINE trial, given that many patients had a lot of toxicity and deaths from infections. In DLBCL, bispecific antibodies continues to chip away at the disease. Something to keep in mind is 3 months. So if not in CR in 3 months, it's time to move on and look for the next line of therapy. Full dose of R-CHOP is probably better for 70 to 79 years of age, as much as possible. In follicular lymphoma, bispecifics continues to look very promising. I did not discuss the other two, but epcoritamab was also presented at ASH and odronextamab. In follicular lymphoma, zanubrutinib with obinutuzumab is now FDA approved for more than 3 lines and beyond. And in CLL, BTK plus BCL2 inhibitors are very promising in treatment-naive CLL, with us having a frontline trial about to open. And pirtobrutinib is also effective post-covalent BTK inhibitors and even BCL2 inhibitors. Thank you. Now, Tarshin will ride us home with Hodgkin lymphoma and T-cell lymphoma talk.
Just provide a quick introduction to Dr. Sethi as we pull up on the slides. So Dr. Sethi completed her medical training in New Delhi and then came to University of Louisville for internal medicine. She went on to Vanderbilt to complete her HEMONC training as well as a master's in clinical investigation. She was on faculty at Vanderbilt for several years before being recruited here at Yale. And her clinical focus is really on aggressive lymphomas, particularly T-cell lymphomas. She has several IATs open or opening soon, and really look forward to her talk on Hodgkin and T-cell lymphomas.
Thanks, Shalin and Scott. So I'm going to go ahead and get started. My job is not as tough as Shalin's is, with not as many diseases to cover. So I have no relevant disclosures. So I'm going to cover 2 abstracts in Hodgkin lymphoma and 2 in T-cell lymphoma. I'm just going to go ahead and get started and talk about the details as we go on. So my first case scenario is that 65-year-old gentleman with hypertension, former smoker, who presents with night sweats in the left neck lump, found to have advanced stage disease based on the PET scan, and the biopsy shows classical Hodgkin lymphoma, nodular sclerosis subtype. So really key issues here is that this is a former smoker and an older adult, which in the Hodgkin world is over 60 years. And we know about these patients is that they don't do as well as patients who are less than 60 years. As we all know, Hodgkin is a disease where overall goal has been to maintain the high cure rates, but to minimize toxicity in the long term. But this is an age group where even our long-term responses are not as good. Primarily, some of it has been because of these patients not getting as intensive therapy, since we know bleomycin has excessive pulmonary toxicity in this age group. And, in the recent era, we know with brentuximab, there is the option of using brentuximab sequentially with AVD in these patients. But still, this is definitely an open area where we need more effective options, as well as, with acceptable toxicity. So this is I just wanted to highlight this real world analysis that was published in 2021, which really showed that patients who received conventional regimens in the front line patients who were older adults receiving conventional regimens did much better than those who did not receive intensive therapy. The study defined conventional regimens as ABVD, AVD, or Stanford 5. And so we do know that these patients really benefit from standard therapy as long as we can have a regimen with a reasonable toxicity. So with this, I am going to discuss abstract 181, which was nivolumab compared with nivolumab AVD compared with brentuximab AVD in older patients, that is more than 60 years of age, in patients with advanced stage lymphoma. So this was a sub-cohort from the SWOG S1826 study. This is definitely a very, very impressive study that they were able to pull off, which is pretty much deals with Hodgkin lymphoma across the lifetime. The COG was involved, and so there were, this included children and adolescents, in addition to, adults and older adults. So this particular abstract reports on the data in older adults. And as I have already mentioned, these patients don't do as well as our younger patients with Hodgkin because of the various reasons, partly because we are not being able to give them, as intensive therapy because of the risk of toxicity. So this study was a randomized 1-to-1 between nivolumab AVD 6 cycles versus BV-AVD 6 cycles. The primary endpoint was progression-free survival. Secondary endpoints were event-free survival, overall survival, and CR, complete response rates. Of the 994 enrolled patients, 97 were over 60 years of age. One key thing was because of the higher risk of infections in BV-AVD, GCSF prophylaxis was required in patients who received BV-AVD, but it was optional in patients who got nivo-AVD. This pre-specified patients, so if it was specified right at the beginning, they could receive radiation therapy to the residual lesions at the end of treatment PET. However, in all the patients that 97 patients that they presented on, none of these patients actually ended up receiving radiation at the end. So the median age here in this particular cohort was 66 years, but they did go up to 83 years. Majority of the patients were male. Again, 86% were white, 3% Black, and 10% Hispanic. And 61% had stage 4 disease, and 47% had high risk IPS scores. So what they, as they report here, so this is pretty impressive data in the patients. Again, this is over 60 years of age. Blue is the nivo-AVD, and red is the BV-AVD. And looking at the progression-free survival, basically at the 1 year estimated progression-free survival with nivo-AVD was 93%, and BV-AVD was 64%. And they reported a hazard ratio of 0.35, which is pretty impressive for an effect size. In terms of side effects, so again, as I said, there's a lot of patients in this age group cannot get intensive therapy because of the risk of side effects. So I think the difference here lies when we look at infection risk as well as overall neuropathies risk, as is expected, as we would have expected, right at the outset. So just looking at any grade, sepsis was definitely more common in the BV-AVD group, as was peripheral neuropathy. Importantly, higher grade neuropathy again was more common in patients who got BV-AVD. In terms of grade 5 toxicity, that's nivo-AVD. In the nivo-AVD groups, there were two deaths, and then in VV-AVD, there were 7 deaths, including 5 due to infection and sepsis. So my key takeaways from the study was that it is definitely appears to be an effective and well-tolerated option in patients who are over 60 years of age. Depending upon the comorbidities, I really do think it might end up becoming the preferred option. At Yale, we do use VV followed by AVD quite frequently in this population if we think for patients, for most of our patients who we think can tolerate it. But we haven't been doing concurrent VV-AVD because of this risk of toxicity that we are also seeing in this particular study. I would really like to see the overall survival data and the mature PFS data. Again, the median follow-up was only about 12 months. NCCN guidelines do list nivo-AVD as a category 2B recommendation for stage 3 for classical Hodgkin lymphoma. So I do think that that gives us the opportunity of trying to get it for our patients, especially I think after this data for our older patients. And I would really consider this first for my patients as long as I'm able to get it versus doing VV-AVD. All right, so moving on to the next abstract in the next case. So again, staying with Hodgkin lymphoma, and this is a 45-year-old gentleman with hypertension, current smoker and baseline diabetic neuropathy, who presents with night sweats and lump in the neck, and again, advanced stage disease. And the pathology is nodular sclerosis, classical Hodgkin lymphoma. So as we can see here, my concerns are that he's a current smoker. So I'm concerned about bleomycin toxicity. He has significant neuropathy at baseline. That's why I'm concerned about AAVD and toxicity with that. So that brings me to abstract 608, which is brentuximab, nivolumab, doxorubicin, and dacarbazine. That is AN plus AD for advanced stage classical Hodgkin lymphoma. This was a single arm phase 2 study. Their hypothesis of testing this was that if we remove the the vinblastine, when you're giving brentuximab, but instead of vinblastine, give nivolumab, and this will potentially reduce the toxicity in this population, especially the neurotoxicity. So this particular study did include stage 2 bulky disease, which is different from the previous study. The S1826 did only included stage 3 and stage 4 disease. So I think that is also important to note for this particular study. This was an open label multi-part phase 2 trial. This particular abstract reported part B, which basically looked at this particular regimen in this population that I mentioned. Part C was looking at more early stage disease. And then patients received up to 6 cycles of treatment. BV dose is what we use with AAVD, that is 1.2 mg per kilogram. And the response assessments were taken at cycle 2 and end of treatment. And the primary endpoint was CR rate at the end of treatment. So in terms of patient demographics, I think they had so this is obviously a younger cohort. Median age was 35 years. And as I mentioned, it did include stage 2 bulky disease along with more advanced stage disease. Although majority of patients were stage 3 and 4 disease. So in terms of response assessment, they found 88% progression-free survival at 2 years. And none of these patients ended up receiving radiation therapy. In terms of end of treatment complete response rate, which was their primary endpoint, they basically had a complete response rate of 88% at the end of treatment. And so again, very, very effective. Again, I think in this population, what we are really looking for is reduction of toxicity and optimizing treatment so that they don't have as much short-term and long-term toxicity. So in terms of adverse events, I think this is important to note that none of these patients had febrile neutropenia. Again, these are younger patients. Peripheral neuropathy was primarily low grade and was reversible basically in all of the patients who did have it. And then even in terms of immune-related side effects, they were not very as significant. They were primarily low grade. Again, this is a single-arm phase 2 study, so the data is not, going to be not as helpful as a randomized control trial, but still, I think it tells us that this is an effective option in these patients with, pretty good efficacy rates. And so I think this is an option we need to keep an eye on for the future for patients who are at a higher risk of infection and neuropathy, where, some of the standard regimens we're using right now are, they're pretty toxic. So, and then in terms of, it also included stage 2 bulky disease. Now, this is a problem for sometimes, we have been following RATL and trying to avoid radiation in patients who, end up being in a complete response. But really, if we can, whatever can help us avoid radiation, those with large mediastinal masses, I think is good. So I'd like to, see more about the data in the stage 2 bulky disease. So that brings us to the T-cell lymphoma abstracts that I'm going to discuss here. Unlike B-cell lymphoma, we do not have a lot of options in this space. And so definitely the more we have, the better it is. Here again, I'm just discussing this case where this patient presents with 45-year-old gentleman presents with night sweats and left neck lump. Biopsy shows it is PTCL NOS and CD30 is negative. This patient ended up receiving CHOEP as first line of treatment, but then progressed and could not go to an autologous stem cell transplant, which would have been standard of care. So in relapsed refractory PTCL, even though we have, various single agent treatments that are an option, but none of them are very effective. The overall response rates are 25 to 40%. And CR rates in the 10 to 20%. So, I'm talking about things like romidepsin, belinostat, and pralatrexate. Those are options, but really not as if, and brentuximab for CD30 positive disease, but they're not as effective. And really, the only curative option in patients with relapsed refractory PTCL is to try to get them to an allo transplant. So we really need more effective options to get us in CR. Thankfully, people are looking at different, pathways to see what could work. And so the first study that I'm going to present is actually looking at the epigenetic therapy, looking at as an EZH1/2 inhibitor, valemetostat. So valemetostat, as I mentioned, is an EZH1/2 inhibitor. So what it does is it basically de-represses the transcription of genes that promote cell death, and basically it helps with it de-represses genes that promote cell death. So this particular study looked at relapsed refractory PTCL that had patients who had received more than one prior line of therapy. Oral valemetostat was used at 200 milligram per day, continuously in 28-day cycles. The primary endpoint was overall response rate at 10 months. This was CT-based, and the secondary endpoints were duration of response, PFS, and overall survival. So looking at the key disease characteristics, the median age was 69 years. Again, the other thing I want to mention is that median lines of therapy, prior lines of therapy was 2. About 24% patients had received prior auto, and then about 4% patients had received prior allogeneic transplant. And in terms of subtypes, it's pretty much reflective of, how common these subtypes are. So the T follicular helper cells subtypes, including AITL, about 40%, PTCL around 31%, and then again, ALCL was also. So remember, for ALCL, Brintuximab, they would have, all patients need to have prior Brintuximab because we know that is effective therapy. So in 119 efficacy evaluable patients, they found an overall response rate of 43%. Again, not much different from the 25 to 40% range that I've already mentioned for our previously known agents. The CR rate was about 14%. The median time to response score is about 8.1 weeks. This is important because a lot of these patients have aggressive lymphoma, and the time to response is important for us, in trying to kind of stall the disease to be able to do anything else. And the median duration of response was about a year. Importantly, as I mentioned, the only curative options for these patients is allotransplant. And so 10 patients in this cohort were able to get to transplant. Even though it doesn't sound like a lot of patients, but for a rare disease like this, really each patient we are able to get to a cure is really important. And so, we'll take all our options. The median, as you can see here, the median PFS was only 5.5 months with the median overall survival of 17 months. So this again tells you anything that you're doing in this line, you're really trying to get them to a transplant if you really want long-term remission. Most of the responses are going to be short-lived. Most common side effect was thrombocytopenia. What was curious was that 2 patients developed secondary AML. Again, this was not with a very long follow-up, but we don't really have much data about this. So I really would like to know more about what is going on there with that risk. So with that, the key takeaways from this study is that valemetostat is an effective option in relapsed refractory PTCL. It's a possible line of treatment. It's currently not approved, so it's not really available clinically. But this is definitely something we would like to see. We know that this is effective in patients also with ATLL, and it's approved in Asia for patients with ATLL. And those relapsed refractory ATLL patients have very limited treatment options. So really want to see how this pans out. But again, I think we needed more data about this risk of AML that was apparent with this smaller cohort study. Okay, so with that, just going back to this diagram. So one of the other pathways that is being looked at in PTCL is the JAK-STAT pathway. And here we, besides the ruxolitinib that we are all familiar with, my next abstract that I'll discuss is looking at golidocitinib, which is a JAK1 inhibitor. So this is abstract 305, looking at golidocitinib in treating relapsed refractory PTCL. This was a multinational study, and it was called JAK-POT8. So this is a selective JAK1 inhibitor. Their rationale for coming up with the JAK1 inhibitor was that most of the side effects, including severe anemias, are related to JAK2 inhibition. And so the idea was to have the efficacy without, with less toxicity. They included 104 patients from Australia, China, South Korea, and United States. And this is an oral agent given once daily. And the phase 2 dose was 150 milligrams daily. So the median age in this study was, in this enrolled cohort, was 58 years with 65% male. What's important to note is that 94% of the patients enrolled were Asian, and then 5% were white, 1% black. 73%, so again, majority here had received 2 prior lines of treatment, and 1% had prior autologous stem cell transplant. Majority of patients had PTCL NOS as their pathology, and then there were other patients with AITL and ALCL and other rarer cohorts. So what they found here again was an overall response rate of 44%. And their null hypothesis was 15%, and the CR rate was 24%. Again, not much different from what we already have with our existing single agents, but definitely, another line, another option in the repertoire. And the median duration of response was fairly impressive. It was 21 months. Here in this waterfall plot, they basically looked at the sum of the products of perpendicular diameters in their assessment using CT. So in terms of their safety population, they reported results of it on their entire cohort of 104 patients. The most common grade 3 and 4 treatment-related events were cytopenias, neutropenia, and thrombocytopenia. And serious adverse events that were seen in 3% of patients, each of these were pneumonia, zoster, thrombocytopenia, and fever. And so really nothing very unusual about this toxicity profile that we would expect. So again, my takeaways from this is that garetosmab is an effective option. Again, it's not approved yet. It has, the main adverse events were cytopenias. And really, I think all of us want to see more data from the US. The reason for this is that we sometimes have disease biology that is different. For example, we know that in ATLL patients, mogamulizumab works very well in Asian ATLL patients, but in our patients from from the South America, mogamulizumab efficacy is not the same as in Asia. So I think sometimes you can have differential efficacy, and so we would definitely want to see more data from the US. I think that brings me to the end of the presentation. Thank you.
Great. We'll open up another short slide deck. We'll have 3 cases and then open up for discussion. Great. Thanks so much for that great summary. So here are my disclosures. So the first case we want to talk about is a 68-year-old, previously very healthy, hadn't really followed with a PCP in many years, eventually developed some fatigue, led to a PCP evaluation, and had routine blood work showing some thrombocytopenia, anemia, and some mild lymphocytosis. The thought maybe was, this patient might have CLL, peripheral blood was sent, and the immunophenotype was atypical for CLL, did not have CD23 expression, and a FISH was sent confirming a cyclin D1 translocation. This patient then had additional testing with a TP53 that was wild type. The next step was to complete staging, and so he had a PET CT, and it showed really non-bulky scattered lymphadenopathy, SUVs less than 10, but notably had pleural effusions as long as splenomegaly. He had a lymph node biopsy, and that confirmed mantle cell lymphoma. The Ki-67 was about 10%. And here we are in 2024. Years ago, this would be relatively straightforward. He's young, under 70, he's fit, and typically would lead to induction chemotherapy followed by a transplant. But are we still doing that in 2024? The real question of that is that we have better subsequent lines of treatment. We have, BTKIs, we have non-covalent BTKIs, we have CAR-T. And so the question of the added benefit of a frontline consolidation with a transplant is in question. That led to a triangle study in Europe, which had 3 arms, randomized patients to standard induction with R-CHOP and DHAP, followed by standard autologous transplant. Then there was 2 experimental arms. One was ibrutinib with the chemotherapy followed by transplant, and then the other actually excluded and did not have patients get an auto transplant. So patients had R-CHOP, DHAP with ibrutinib, and then had just 2 years of ibrutinib maintenance. This study was presented at last year's ASCO and was quite notable at a median follow-up of 31 months. Freedom from progression was effectively identical. In fact, there was a numerical benefit of the chemo-ibrutinib arm. So that was a splash. It hasn't been published, but many institutions throughout the world are questioning transplantation. That study came out at a time when the ECOG study was accruing quite well. And this is an MRD-directed transplantation study for mantle cell. Patients receive standard chemo for induction and then have NGS adaptive assessment of MRD positivity. And if they're positive MRD, standard of care would be to take a patient to transplant. The majority of patients after novel kind of upfront or modern upfront induction will actually be MRD negative, and those patients are randomized 1-to-1 to either transplant or no transplant. Each arm gets rituximab. So Shalin, how are you having this discussion today with your patients that are transplant eligible?
The frontline mantle cell lymphoma discussion is usually a 1-hour discussion in clinic now. It's become very complicated for all the good reasons because, as you said, like it ranges from very intensive therapy like triangle, where the R-CHOP cycles would be in combination with ibrutinib versus RDHAP would be inpatient admission for 3 days, followed by 2 years of ibrutinib plus rituximab maintenance. This is further complicated by the fact that the FDA, the approval for ibrutinib in mantle cell lymphoma was withdrawn, which makes it a bit complicated because in clinical world, we think that all other covalent BTK inhibitors are swappable. So, I have used triangle study-based approach in clinic with zanubrutinib, but usually I would reduce the dose given the cytopenias. So that's one thing. And I think this particular patient, young, fit, I would definitely have a very lengthy discussion about triangle. And if they seem to be agreeable to it or if it fits with their goals, because there are many patients who have immediate goals where they don't want any significant impact to their quality of life. And in those cases, I also discuss, bendamustine rituximab with or without cytarabine containing, alternate cycles. Going all the way to BTK inhibitors alone with or without rituximab. And I think we have a trial over here, which I'm sure we will talk about. And I think biology is also important, right? So just the fact that this patient is fit is not enough now. So biology trumps everything. And if they have TP53 mutation, ATM deletion, or complex karyotype, that would definitely sway me towards using more novel approaches.
Great, thank you for the summary. So our patient, he really, wanted to continue to feel well, minimize the amount of inpatient therapy, and went on to receive our bendamustine for 3 cycles. Did have intensification with cytarabine, and then had restaging evaluation. Importantly, had a PET CT in a bone marrow that confirmed a CR. He was not, set on getting a transplant, and did enroll in this clinical trial where MRD was undetectable, and he has been randomized to the maintenance rituximab arm. So, this is a trial that's still open at Yale, and given the uncertainty, I do think that this is a really important study that we want to fully accrue and get the outcome to really guide our management for patients. And then you kind of mentioned, what do we do for patients that are not transplant eligible? Patients in their 80s, do we give bendamustine? Do we give chemotherapy? Do we give novel agents? And for that, we do have the Alliance study presented here for patients over 70 or those younger with severe comorbidities. This non-chemotherapy-based option is quite reasonable. So patients get zanubrutinib and rituximab, and if they're in remission, then randomized either to a discontinuation strategy or zanubrutinib indefinitely. And so we really enjoy seeing those patients that potentially could benefit from this study. The second patient's a 57-year-old who developed some weight loss and cervical adenopathy. They had the appropriate excisional lymph node biopsy, which showed bizarre cytologic large cohesive cells that looked anaplastic, and sure enough, on immunochemistry, they were CD30 positive, otherwise negative for ALK1 and CD20. How do we manage ALK negative anaplastic large cell lymphoma? And the data really is strong from Echelon 2. This is the 5-year update, which randomized patients to CHOP versus brentuximab CHIP. And you can see here that the progression-free survival has been maintained. And this certainly is a new standard of care for patients with CD30 positive T-cell lymphoma. Question for you, Dr. Harshin, would be, how do you consider patients for an upfront autologous transplant in the era of Echelon 2?
Yeah, thank you. So definitely, the BVCHP has really helped improve the prognosis of this subset of patients, that is ALCL. We know that ALK positive ALCL with BVCHP, the long-term response rates are very similar to, and the long-term prognosis is similar to that of diffuse large B-cell lymphoma. So those are patients that can potentially, forego autologous stem cell transplant in first remission, that is ALK positive. Patients with ALK negative ALCL, in most part, almost everybody will be offered autologous stem cell transplant as long as they are eligible. The reason being, even though we know that DUS22 positivity actually gives them a good, it's a good prognostic factor. And the outcome for these patients can approach that of ALK positive ALCL. But in practice, again, this is a rare subtype of another rare subtype. We don't have enough data to just basically forego transplant in these patients. Yes, so ALK negative ALCL, we're still offering autologous stem cell transplant in first remission.
And this patient's receiving treatment and likely will go to transplant. For a large percentage of patients with T-cell lymphoma that are not overexpressing CD30, options are quite limited. But fortunately, we will have an upfront study opening in the near future with MOGA. So MOGA is an antibody against CCR4. It has activity as a single agent in TALL and also CTCL. So this study will be opening with Dr. Sethi as the PI. Really, I think for patients that have a new peripheral T-cell lymphoma, getting them in to be seen for this study is important. The trial, I think, was written very well in the sense that these patients often are quite symptomatic and need kind of urgent therapy. And so this does allow enrollment after a single cycle of CHOP or CHOEP-based therapy. Our third case is a 54-year-old with CLL. He's had CLL for well over 2 decades, received chemotherapy in 2010, had a very short duration of remission, had RCVP, followed a year later by arbendamustine. Fortunately, novel therapeutics in the BTKI space were approved, and the patient derived a clinical benefit for close to 8 years with ibrutinib. Around 2020, he started developing progressive lymphocytosis, but otherwise feeling well, and his therapy was switched to rituximab and venetoclax. He's now towards the end of 2 years of venetoclax, and it was referred in to discuss next steps. And really, do we have a role of allogeneic stem cell transplantation for CLL? This is the data that I think about when I see a patient like this that has had CLL for decades, that is heavily pretreated both with the BTKI and BCL2. Allo transplant historically has been a curable modality for CLL. I typically would think about 1/3 of patients will have a long-term cure, 1/3 will have progression, and 1/3, unfortunately, will have significant complications. We don't have a ton of data of using allo transplants in the novel era because most patients do not need that. But for our young patients like this, allo transplant still is a potential consideration. This was some data published a few years ago where patients had to have at least one exposure to a novel agent. That did include BTKI, PI3K, or BCL2. And what's notable is that the PFS looks quite similar whether you had an exposure to just one agent or two agents. And so certainly allotransplant for our patient is a consideration. It's hard to move to that way in the era of pirtobrutinib and the fact that CAR T was just approved for patients like this. Dr. Kathari did a nice job presenting the pirtobrutinib data. Median PFS is just around 16 months in those that are exposed both to BTKI and BCL2. Certainly a meaningful PFS there. And then in terms of potentially curative therapy, liso-cel is presented here. Busy slide. The median PFS for the entire group was under a year, but somewhere between 20, perhaps 20 to 30 patients, percent of patients will derive really meaningful benefit, including those that have CRs that sometimes can actually be durable, and a subset we think could be cured. And so for this patient, knowing that we have these therapy options, along with really encouraging clinical trials that are entering our space in the next couple of months, this patient is deferring an allotransplant, but will be HLA typed. In terms of the two trials I do want to mention here that will be opening at Yale in the near future. The first is a BTK degrader, really compelling preclinical work in this space, a recent Science publication here, where it's not only the tyrosine kinase activity, the BTK, but perhaps scaffolding that allows pathogenesis in B cells. As a degrader, you're actually able to really target both the TKI, but also reduce the protein and the effect of scaffolding. So this study will be opening as a phase 1 with very broad inclusion criteria in the next few weeks. The other trial that I have in mind for this young patient is a MALT1 inhibitor. So certainly compelling preclinical data of targeting downstream to the BTK, particularly the pathway towards NF-kappa B activation, and MALT1 is a really interesting target there. And we'll have a phase 1 study of AbbVie 5225, and Dr. Kathari is going to be the PI on that. So with that, I'd like to open it up broadly for questions.
I want to retire. Just, with PERTO resistance, we're seeing a lot more of it. Jeff Brown presented that at ASH, and just the issue for patient care and sequencing of non-covalent and covalent BTKIs. I know it's gaining a little bit of traction now. It's new to us with the gatekeeper, but what have you been seeing? Anyone here in general, any thoughts? Because some issues now sequencing these covalent and non-covalent. The more that we're seeing, so just your thoughts on that, why
Okay.
I think in that study that I talked about doing, there were patients who had not received the covalent BTK inhibitors at all, and the curves looked amazing. It was like basically a straight line, but it's still very short follow-up, right? So we don't necessarily know whether non-covalent BTK followed by covalent is better. I think only time will tell us. Ultimately, we have to basically develop randomized trials to compare this.
No, I know they've reported 6 cases, with the Farber, and then MSK has seen some.
Yeah, there are many other point mutations developing in the BTK. So, and that's exactly why I think the degraders are going to be very important as well.
And it also might argue for fixed duration, right? Combining with the BCL2.
Yeah.
Can I just ask a very broad question? I think in CLL, which is a very common disease, we have so many agents. Could you break it down for us and educate on ABC? So how you approach frontline treatment for newly diagnosed CLL treatment?
Yeah, that could be another hour presentation as well. But no, I think it's still right. So if a patient has a mutated heavy chain, does not have a deletion 17p, I have a hard time giving a continuous BTKI in the frontline setting. Patients have deep remissions with BCL2-based therapy, and lasting years and years and years. And so, simplistically, if someone has a mutated heavy chain, non-del 17p, non-TP53, I do favor venetoclax-based treatments. In patients that have an unmutated heavy chain with or without 11q, 17p, that's where I think BTKIs really are important. And in fact, combining BTKI with BCL2 in that subset looks really phenomenal. And so we're going to have that study available. So, patients have mutated heavy chain. I think GVen makes a ton of sense. For patients that have a unmutated heavy chain or high risk features, combining a BTK BCL2 is really the way forward for the front line. Any other questions? Thanks, everyone.
All right, so wonderful discussion and great selection of the abstracts. Thank you to all of our discussants and speakers. We are exactly on time. It's 10 a.m. So we will now take about 15-minute break and return to start with the myeloma session. Thank you, everyone. Is devoted to multiple myeloma. And our speakers for this part of the program are Dr. Carrie Parker, who's our faculty since 2012 at Yale, leading multiple clinical trials as a PI, a national PI, and she's our clinical lead for the outpatient ambulatory hematology and myeloma group operations. And we also have Dr. Nofar Bar, who's been on our faculty since 2016, has been leading clinical trials involving CAR T-cell therapies and bispecific therapeutics. We're also joined by Dr. Talib Dosani, who's also our alumnus and doing myeloma care and general care also at West Haven VA and doing some research projects with myeloma. And finally, this session will be moderated by Dr. Ilan Gorshine, who's part of myeloma group and providing care to patients with myeloma and other hematologic malignancies, both at Guilford and at North Haven Myeloma Program. So why don't we go ahead and start?
Okay, so we're going to start off with updates from ASH in the newly diagnosed setting. I have no disclosures. So when we talk about frontline treatment for multiple myeloma, we really need to acknowledge the evolution over the last 10 to 20 years. We started with doublets, moved into triplets, and now all the rage is quadruplets. So the foundation for quadruplet therapy really stems from the Griffin clinical trial. So this was a phase 2 study, again, in newly diagnosed transplant-eligible myeloma patients. Patients were randomized to receive treatment with 4 cycles of induction, which consisted of either daratumumab in combination with lenalidomide, bortezomib, dexamethasone, versus the triplet of lenalidomide, bortezomib, and dexamethasone. Following 4 cycles of induction, all patients received autologous stem cell transplant, then 2 cycles of consolidation, and then maintenance for 2 years. The primary endpoints of the Griffin clinical trial were stringent CR rate by the end of post-autologous stem cell transplant consolidation, with multiple secondary endpoints listed here. In looking at the results of the Griffin clinical trial, it met its primary objective as a stringent CR rate post-consolidation of 42.4% in the DARA group versus 32% with the triplet. And you can see in looking at the secondary objectives listed here, overall response rate, VGPR or better, and MRD negativity rate were all improved with quadruplet therapy. More recently, it's been shown that the combination of the DARA, lenalidomide, bortezomib, and dex has also led to increasing depth of response and MRD negativity, which you can appreciate in the graphs here. So some of the criticisms of the Griffin clinical trial was that it was a phase 2. It was also had a small number of patients that had high-risk cytogenetics. So that brings us to the first trial that I'd like to discuss from ASH, which was the Perseus trial. So this data was presented at ASH and then published in the New England Journal of Medicine this past January of 2024. So this is the phase 3 trial of daratumumab in combination with bortezomib, lenalidomide, and dex versus VRd alone, again, in patients who are newly diagnosed and transplant eligible. So a total of 709 patients were randomized to receive the triplet. Bortezomib was dosed 1, 4, 8, 11. Lenalidomide was days 1 through 21. So these are 28-day cycles. So it differs slightly from how it was administered in the Griffin trial, as that was a 21-day cycle. And the dexamethasone of note was days 1 through 4 and 9 through 12. So a little bit higher dose of dex here. All patients received 4 cycles of induction, followed by autologous stem cell transplant, 2 cycles of consolidation, and then lenalidomide maintenance. The other arm was VRD with the addition of daratumumab. Again, transplant, 2 cycles of consolidation, then DARA and lenalidomide maintenance for 24 months with the possibility of discontinuation of the DARA if MRD negativity was sustained. Sustained here was defined as greater than 12 months. So the primary endpoint was progression-free survival with secondary endpoints of overall CR rate, overall survival, and MRD negativity. In looking at the 2 treatment arms, they were really well balanced. In looking at ISS stage 3 disease and high-risk cytogenetics, 55 versus 50 and 76 versus 78 patients in each arm. So in looking at the progression-free survival, this graph is actually taken from the publication. The median follow-up was 47.5 months. So they reported out the 48-month progression-free survival of 84.3% in the quad versus 67.7% with the triplet. And importantly, they also noted that progression-free survival was improved across all clinically relevant subgroups. So this is what you can see here, specifically if we look at ISS stage 3 disease and as well as high-risk cytogenetics, you can see that everything is favoring the quadruplet, so the addition of the daratumumab to the VRD backbone. They also commented on overall and sustained MRD negativity rates. So they looked at MRD via next-gen sequencing, both at 10 to the -5 and 10 to the -6. The green bars are those for the quad and the blue are the triplet. And in looking at 10 to the -5, you can see it was 75.2 versus 47.5%. This held when looking at 10 to the -6, 65.1 versus 32.2. So the conclusions that were drawn by the authors were that the quadruplet induction followed by autologous stem cell transplant, consolidation, and then daratumumab lenalidomide maintenance significantly improved progression-free survival versus the triplet induction. Again, the 48-month progression-free survival was 84.3 versus 67.7. The quadruplet significantly improved depth of response. Again, CR rates 87.9 versus 70.1. Overall MRD negativity at 10 to the -5, 75.2 versus 47.5. And even more impressive, I think, is that 64 patients who did receive the daratumumab lenalidomide maintenance for at least 2 years were actually able to stop the DARA as they achieved sustained MRD negativity. The safety profile was consistent with that's known for the daratumumab subcutaneous and the triplet of lenalidomide, bortezomib, and dex. So the ultimate conclusion was that the randomized phase 3 trial supported the use of the quad DARA, bortezomib, len, and dex, followed by DARA lenalidomide maintenance as a new standard of care for transplant-eligible patients in newly diagnosed multiple myeloma. So this is a clinical trial. So all these patients are highly selected, they're highly motivated. So what about real-world data? Can we translate this? So I want to highlight one abstract that looked at that, and this was presented by Dr. Joseph et al., and this is data from Emory. So they wanted to compare response and survival outcomes in newly diagnosed transplant-eligible myeloma patients, again, treated with the triplet versus a quadruplet. They had 326 evaluable patients who received a quad induction at Emory between April of 2018 and August of 2022, versus 1,000 patients who had the triplet. In their trial, they had 4 cycles of induction, followed by autologous transplant, and then either lenalidomide maintenance or a PI-IMiD combination if an individual is considered high risk. They defined high risk as deletion 17p, translocation 414, and translocation 1416. What's notable here is that they did not do any consolidation, and there was no daratumumab-based maintenance. Their endpoints primary were CR rate, and then secondary VGPR, progression-free survival, overall survival, and MRD negativity. Of note, they had 45 patients who were considered to be high risk in the quad, and another 79 patients who had a gain of 1Q, as that initially was not considered to be high risk. And what they noted was that responses deepened over time. So the first 2 graphs look at triplet therapy. The second 2 are the DARA-based combinations. So you can see that for both RVD and the DARA RVD, post-induction and then post-transplant, the rates of CR and the rates of VGPR increased. They noted an improvement in progression-free survival that favored the quad group. At 1 year was 98 versus 93%. But then if you fast forward to 4 years, it was 85 versus 61% for progression-free survival advantage for those who got a quadruplet. Overall survival at 2 years was 94 versus 91%. So these were large cohorts of consecutive and uniformly treated patients, and they showed that their data was consistent with that of the clinical trial experience that's been reported. They demonstrated an improved depth of response and survival benefit of a quad versus the triplet, and they noted that this response was maintained across all notable subgroups. So by that, they looked at individuals who had that RISS stage 3 and also high-risk cytogenetics. They also wanted to highlight the role of single-agent lenalidomide therapy and suggested that additional studies are needed to determine the ideal maintenance strategies based on that risk group. And again, follow-up was limited here in this cohort. Their median follow-up for the quad was only 18 months, but they did show an early benefit, which is expected. And then this just highlights the 4-year progression-free survival of the Emory data, which was 85%, in comparison to that of the Perseus, 84.3%, and compared to the Griffin, which was 87%. So the real-world data, at least in the Emory experience, holds up with what we're seeing in that phase 2 and that phase 3 clinical trial. Okay, and now this was kind of the big one, which was presented at the plenary session, which also focuses on quadruplet therapy. So this was the Ischia trial, which was presented by Dr. Gay. So this was isatuximab in combination with carfilzomib, lenalidomide, and dexamethasone versus carfilzomib len-dex as pre-transplant induction and post-transplant consolidation. So this is a little bit of a different design. So as far as the post-transplant treatment. So 302 patients were randomized to receive a triplet. So carfilzomib, here it was dosed at 20 mg per meter squared at cycle 1, day 1, followed by 56 mg per meter squared weekly. Lenalidomide as a 21 out of a 28-day cycle, and weekly dexamethasone, followed by autologous transplant, 4 additional cycles of consolidation, and then what they're calling light consolidation, which was a 12 additional cycles that utilized carfilzomib, but on a days 1 and 15 schedule, a lower dose of len at 10, and then still continue the dexamethasone at 20 milligrams. Versus the quad, which was the same dosing regimen for KRD, but added isatuximab IV weekly. And then in the consolidation, the isatuximab was given on days 1 and 15, and during the light consolidation, it was given on day 1. So the primary endpoint of this trial was MRD negativity post-stem cell consolidation, with secondary endpoints of MRD negativity following induction, looking at sustained MRD negativity, and then progression-free survival. Importantly, the treatment arms were well-balanced, and if we look at some interesting features, you look at high-risk cytogenetics, 25 versus 26 patients in the 2 arms, the number of high-risk cytogenetics, those who had 2+ high-risk cytogenetic abnormalities, 13 versus 15, and in both arms, 10 patients apiece were considered to be RISS3. So when you look at the primary endpoint, which was post-consolidation MRD negativity, they looked again at 10 to the minus 5 and 10 to the minus 6. The green bar is the quad versus the blue is the triplet. So in 10 to the minus 5, MRD negativity was 77 versus 67%. And then if you go even further at 10 to the minus 6, it was 67 versus 48%. And they did see that this benefit was maintained across their subgroup analysis. So I just want to highlight one of those subgroup analyses that I found very interesting, and that was the subgroup analysis by cytogenetic risk. So they broke down MRD negativity based on 0, 1, or 2+ high-risk cytogenetic abnormalities, with 2+ considered to be very high risk. And what's interesting is that the MRD negativity rate holds for these patients. So at 10 to the minus 5, it was 77 versus 53%, favoring the quad. And even at 10 to the minus 6, 77 versus 27%. So the conclusions that were drawn from the Ischia trial was that the quad of isatuximab, carfilzomib, lenalidomide, and dex increased post-consolidation at both 10 to the minus 5 and 10 to the minus 6 MRD negativity compared to a triplet. We also saw that the MRD negativity improved after each treatment phase. meaning induction, transplantation, and then consolidation. The improvement in MRD rates held throughout all subgroups, including those with high risk and very high risk disease. Treatment was tolerable, so the toxicity profile was very similar to what's been reported with other studies of isatuximab individually and KRD. They felt that 10 to the -6 was a more informative cutoff versus 10 to the -5. They're hopeful that the 1-year sustained MRD negativity will be available in 2024, as that was not presented. And with longer follow-up, the trial has the opportunity to explore the correlation between depth of MRD negativity and how that relates to progression-free and overall survival. So we know that the median age of diagnosis here in the United States for myeloma is 69. So all the three prior abstracts all focused on transplant-eligible patients. So what about our transplant non-eligible patients? So I want to highlight one trial in the non-transplant eligible, and this was the GEM 2017 FIT trial. So this was presented by Dr. Mateos, and the data is primarily conducted in Europe and Spain. And so hence why their induction therapy was VMP followed by RD. Melphalan, allocated prednisone, so things that we don't typically use here. But in prior data, VMP RD in patients younger than 80 resulted in MRD negativity rate of 20%. So the hypothesis of this trial was to try to increase the MRD negativity rate to up to 35% in the 2 experimental arms. So what are those arms? So this was how the study was randomized. So 154 patients, 154 and 153. So patients either received 9 cycles of VMP. So again, bortezomib, which was given twice weekly for cycle 1, and then weekly for cycles 2 through 9. Melphalan was 9 mg per meter squared, days 1 through 4, and then prednisone, followed by another 9 cycles of lenalidomide and dex versus carfilzomib Lendex. It should be noted that the carfilzomib dose here was 36 mg per meter squared IV, twice a week for cycles 1 through 2, and then it changed to 56 mg per meter squared weekly. Versus the quad, Dara, carfilzomib, Rev Dex, and both the KRD and the Dara KRD were given for 18 cycles here, because again, these were transplant ineligible patients. This was followed up by consolidation with Dara combined with lenalidomide and dexamethasone. The primary endpoint was MRD negativity after 18 cycles of induction, with secondary endpoints of MRD negativity after consolidation. So they looked at fitness, and meaning they wanted to enroll fit elderly patients. So the fitness here was assessed based on chronological age. So they included patients again 65 to 80 and utilization of the geriatric assessment hematology score. For those not familiar, the geriatric assessment in hematology is a 30-item tool that's grouped into 8 relevant geriatric dimensions. So they look at number of drugs taken, gait speed, mood, ADLs, subjective health status, nutrition, mental status, and comorbidities. The lower the score, the better someone's status. So the sum of the score could range from 0 to 94, and the cutoff point here was set at 42. So they did have 56 screening failures for this trial because their geriatric assessment score was over 42 and they were deemed ineligible. So in looking at the primary endpoint, which was MRD negativity after 18 cycles, the green bars show MRD at 10 to the -5, blue 10 to the -6. And you can see if looking at 10 to the -5 in their standard arm, VMP followed by RD, it was 33%. That significantly increased to 75% with the triplet containing carfilzomib, and then 84% if you do the quad. You can see the CR rates and the 30-month progression-free survival also all favored the quadruplet of Dara, carfilzomib, lenalidomide, and dexamethasone. So this table is a little bit busy, but I think it's important because the main question is these are, again, elderly, non-transplant eligible patients. So what about toxicity? What about early discontinuations? So the number of patients who discontinued treatment across the 3 arms was similar, which you can see at the top, 49, 43, and 40. But the reasons for discontinuation were slightly different in each group. This graph shows the time to early discontinuation, the percent who discontinued secondary to toxicities, what those toxicities were, the number who had toxicity-related death, And then they looked at specifically the number of individuals who had a geriatric assessment greater than 20 who discontinued. So the take-home messages from this very busy table is that the probability of discontinuation due to progressive disease was lower for individuals who received carfilzomib-containing regimens compared to the VMP followed by RD. The probability of discontinuation secondary to toxicity, however, was higher in KRD, as well as toxicity-related death in the quad. In the KRD arm, again, toxicity was higher, but there was not a trend to any specific toxicity that led to discontinuation. Toxicity-related deaths in the 3 arms were mainly secondary to infection, and there was a trend for patients who had a geriatric assessment of greater than 20 to discontinue because of toxicity or toxicity-related death. And this was especially true if we saw higher scores that were concentrated on gait speed and nutrition. So the conclusions from this study was that the phase 3 trial met its primary endpoint, which was the MRD negativity rate at 10 to the minus 5 after 18 cycles of induction. And you can see here that was 75 or 84%, which was significantly higher than their standard. The 30-month progression-free survival was also higher at 83 and 79% versus 73%, and that the rate of discontinuation was similar across all 3 arms. And they finally note that although more studies are required, the geriatric assessment and hematology score could possibly project toxicity and mortality, and therefore could be very useful to help guide our therapeutic selection between triplets or quadruplets in this elderly population. So I think definitely when you look at all the upfront abstracts this year at ASH, the theme really was we should be doing quadruplets as first-line therapy, even in elderly patients if they are fit. And with that, I will stop and turn it over to Dr. Barr for updates on relapsed myeloma. Thank you for your attention.
Thanks, Carrie. Hi, everyone. I'm just waiting for my slides to come up. All right, so we're going to be shifting gears right now to the relapsed refractory myeloma highlights from this year's ASH. And I have no disclosures. As many of you know, there's been a lot of excitement in the last 3 years with the approval of several T-cell redirection therapies, including bispecific T-cell engagers, as well as CAR T-cell therapy. For this particular talk right now, I'm going to really be focusing on the T-cell, the T-cell engagers, and I'm going to reserve the CAR T discussion for later after you've had your lunch. So, with a lot of excitement also comes a lot of questions. And some of the questions that were addressed at ASH, I put up here, which I'm going to be discussing some of these abstracts. So first, is efficacy and toxicity the same in the real world? Second, can toxicity be reduced? Third, can combination therapies improve efficacy? And last, what's coming up next? What about the next generation T-cell?
We presume you actually get all 6, and this one definitely is one which should get its recognition. Starting with low-risk MDS, this is a disease that the patients burdened with this disease suffer from cytopenias. This is the syndrome that these patients encounter, and it can be quite actionable. This is really the one thing that I say patients most often feel, and much of what we do to treat this disease is really not intervening upon it, but rather dealing with which the disease, the things with which the disease comes. Anemia being, again, the dominant one. We have a couple of tricks that we can try, but there is I'd say slowly, but I'd say reasonably expanding class of agents that were first kind of deemed as being the TGF-beta ligand traps, but now we're progressively trying to use the terminology erythroid maturation agents. Most of us here are familiar with luspatercept, but one of the abstracts I wanted to highlight was a similar product made by Keros. This is Keros 050. It does have a name here, which usually, again, is a good sign. And much of this MOA is hypothesized, but suffice it to say, this is thought to gobble up this TGF-beta ligands, which mediate a lot of the pathogenesis of this disease. And this product is selectively binding. It's a couple, but in this case, one of them is activin A, and eventually is thought to rebalance this TGF-beta signaling, which one of the main goals, obviously, given this primer, is to improve erythropoiesis, but also thrombopoiesis and a couple of other things you see here. This is at least the schema that was provided at the meeting. You can see here, well, you can't see here, but I'll just tell you that some of the other eligibility criteria that were relevant, this is obviously low risk disease using some of the classical scoring systems. Patients had to have anemia, not necessarily transfusion dependent anemia. In fact, we'll see in the next slide that some patients actually were not yet transfusion dependent. After this dose escalation, it was extended into several cohorts by transfusion burden, and the classical threshold above which we say a patient is highly transfusion burden is greater than 4 units per 8-week period, as well as RS status and iron overload, plus or minus the use of iron chelation therapy. So pretty relevant populations that we encounter in the clinic. And the primary endpoint of this trial, which is one which is at this point, you can say classical, it's really the precedent that's been set, especially for regulatory approval, was 8-week RBC transfusion independence. I should note this is a product which is given sub-Q, just like luspatercept, but maybe a nominal difference, but every 4 weeks compared to 3. Here is, again, just a brief outlook with regards to the baseline characteristics of this population. Nothing too surprising by way of median age or some of the patient-specific factors. I'd also call your attention to the proportion of patients that had RS-positive disease, which is not dissimilar from other trials that have, studied luspatercept. Same goes for the baseline EPO level, which generally predicts a response to ESA and perhaps even these agents. One of the key features of this abstract, which is why I think it was important to review it, this is a largely highly transfusion burden population. You can see here that in this case, it was the majority of patients that actually were highly transfusion burden, but about a third actually were requiring more than 6 transfusions per 8-week period, essentially weekly transfusions, which over time, actually not too much time, begets the risk of cumulative iron overload. The tox profile here, I didn't want to belabor it, but higher level indirect on-phos comparison, largely similar to luspatercept with regards to the GI tox, fatigue. And most of these were grade 1 to 2, as you can see here. There were 2 cardiac quote-unquote events, which suffice it to say were, as per the investigators and the sponsor, thought to be unrelated. So did this help patients? I mean, it's a single-arm trial, but the overall response rate was, I wouldn't call this nothing to sneeze at. This is, half of patients actually did enjoy some form of response, including, I'll harp on this a few times, those that were highly transfusion burdened with a 40 to 45% rate of response. Some differential responses noted based on the disease's RS status, but this is something which, for this specific type of disease, low risk MDS, this is, we should mention non-del5Q, maybe no path to getting ESA reasonably, and the disease is RS negative. We kind of have limited options. There are some things we can use. We can use, this kind of stuff off label. We can use lenalidomide, but I would say this is definitely maybe carving out a niche in a specific area. There's one thing we haven't discussed, and it's imetelstat, but for those of you that were at the analogous session or a gathering in the summer for the ASH Review, something was truly very solid data set. That's another competing product. The duration of response, again, the median follow is still a little short here, but you can see it's quite favorable compared to historical control. So where this product might fit in the MDS treatment landscape is yet to be seen. You have to have a different maybe trial design, obviously maybe some randomized data. But I think one of the more important features of why I chose this abstract was the fact that maybe there are some maybe not so subtle differences in population studies compared to luspatercept treated patients. Now, these patients were unequivocally highly transfusion burdened. Switching gears to higher risk MDS, I had to pick one abstract. And this was one which, we kind of had our eyes on for a while, this trial on Jacqueline Garcia's trial. This is a single-arm phase 1b trial of the addition of venetoclax. Everyone knows this is a BCL2 inhibitor, plus at least the standard of care for most, if not almost all patients, HMA, in this case, azacitidine. It was high-risk disease, as you would expect, to kind of justify, or at least maintain equipoise in delivering this to higher-risk disease. Less than 20% blasts, kind of below that, at the moment, still fairly firm cutoff that defines AML. Some other eligibility that you can see here. The primary endpoint of this trial was CR, using the IWG 06 criteria, which akin to the last abstract is one which is really identified as having, not only precedent, but again, regulatory approval. AZA given on the classical dosing schedule, but with attention to Ven being given on days 1 through 14, just to really mitigate, at least attempt to mitigate some of that toxicity that's encountered. What we know Ven can do when we give it for AML, we give this combo like water for AML. So why not higher risk MDS? Speaking of what we know what Ven can do, about half of patients did encounter significant cytopenias, emphasis on significant by way of the clinical sequelae that were encountered. Infections, some hospitalizations, of course, with, for episodes of febrile neutropenia. But, in the end, I'm not trying to minimize this, but I would say only 10% rate of discontinuations due to AEs, which is, in all honesty, the going rate for these types of combinations in myeloid trials. And same goes for the 60-day, what we generally call the early mortality, in the 5 to 7% range. So did this toxicity come at some benefit? Eyes of the beholder, and certainly in a single-arm trial while we await the data from the randomized phase 3 Verona trial. But this is an update, and I think one which is still quite reasonable, hence why I included as abstract number 2 in this presentation. You can see that 30% of patients achieved CR, which compared to what we know from AZA 001, which was the landmark trial in high-risk MDS from at this point 15 or so years ago, is, I would say, a little bit more than double after adjudication and some of the real-world analyses as well. In using the IWG-06 criteria, there are not many less than CR responses outside of marrow or morphologic CR. So this doesn't really come with count recovery. The patient achieves less than 5% marrow blast, but no count recovery. And of course, it's coming with these infections. But half of patients that can, quote, clear blasts, this is generally felt to be, even though it's still insufficient of a response compared to true CR, felt to be sufficient for a patient to proceed to transplantation, which in this case occurred in about 40% of patients. It's actually quite high compared to real world estimates, maybe not so dissimilar from other trials. And I would probably, my suspicion is that patients that would otherwise enroll in the single-arm trial were likely those who the providers were actually already kind of planning to transplant them. So you're, obviously it's a healthier trial population, but these are folks who are, I think, in my estimation, are already planning to go to trial, transplant, but they just need something to kind of get them over the hump a bit quicker. And we saw on the prior slide that the median time to response was quite attractive. Again, we need a bit more follow-up. You can see that half of patients are alive at 2 years, which looking at harkening back to AZA 001 is kind of the same, but real world estimates, this is about double. We have to come back to the fact that this is not randomized data. We await Verona again. It's waiting it for quite some time. But this is certainly I think aligns with our anecdotal experience with what this combination can do. There's perhaps some selection for patients that, at least in our practice, have blasts, marrow blasts, usually bordering on AML, or they have more of a terrible symptom burden or disease burden where they need maybe more of an expedient response. And certainly those that have a great donor and are planned to prioritize cure for the transplant. Okay, so now we have to switch gears, and I don't have left, there's no timer, but we have to talk about menin inhibition. This is an area within AML, it's currently AML and ALL as well, and maybe even some of the MDS coming down the pike. We now have seen data for 5 of these small molecule inhibitors that are really thought to interrupt this interaction between menin and the fusions that are created with KMT2A rearrangements. And in the end, this is thought to lead to HOX-mediated, leukemogenic HOX-mediated transcriptional programs which beget the disease. We're going to focus on AML in this case. And why is this important? This is because look at this bottom KM curve. Starkly different than the other curves you've seen from other groups. This is what our curves kind of look like. The median overall OS in this population is fairly large given the biological restriction is less than 90 days. This is data presented by Dr. Gus Issa from MD Anderson, who actually delivered the next slide we're going to see. So we did see data for at this past ASH for 5 of the 6 here, the lone product, which is the cure product, ziftomenib. We didn't see data this past ASH, but the others we did. In picking one, I would like to talk about revumenib, which is the Syndax product. And we'll specifically talk about Augment 101, which was a phase 2 study in, I would say it was pediatric inclusive, but all patients with KMT2A rearranged leukemia. So not only AML, there were some ALL, we'll see some of the
the demographics in a little bit. I would note this is an oral monotherapy for patients. I didn't specifically say this, but in the salvage setting. So leukemia that's KMT2A rearranged in the salvage setting. The primary endpoint here, and again, there's a theme. This is a composite remission rate, CR/CRh, which has sort of been prioritized for a regulatory benchmark. So this is why this was chosen, even though we will talk about some of the less than CR responses, which in the clinic we do regard as being meaningful. This is just I think my adaptation of a table one. I did some copying and cutting here. You can see that this was a largely younger population, mostly AML. Here's some of the commutations outside of the rearrangement that was required for this cohort. I put a big red box around this kind of bottom of the table, because this is really the main takeaway for me, and we'll get to the efficacy, but efficacy can only really be viewed through the lens of the population that's being treated, right? So I would note that even though the median prior lines of therapy is 2, you can see that 46, so almost half the patients who had their disease has been exposed to at least 3 lines of prior therapy, half at prior transplantation that failed them, and about 3/4 of patients had been exposed to originally failed by venetoclax. So essentially you have 4 or 5 of the worst things that we don't want to see in a patient or their disease. This is obviously leukemia, acute leukemia, KMT2A rearranged in the salvage setting, post-ven exposure/failure, and they're on top of a little post-transplant relapse. These are the patients that, outside of TP53, I would argue are the hardest to treat. But we'll talk about toxicity first. Given these high stakes, hope I didn't really overstate it, but I would truly use the term, it's hackneyed, I'd say, throughout ASH for every darn presentation, but this is truly acceptable, I would say. You will note that there was some GI toxicity that was encountered, which generally they don't let us graduate without knowing how to fix these things, or at least mitigate them to the point where it's tolerable, but they were quote unquote lower grade. There was 28% rate of differentiation syndrome, which got a lot of press over the last year and a half, 2 years. Most of us kind of accept now this is evidence of on-target effect, and probably predicts response akin to what we know adjuvant arsenic can do for APL, the IDH inhibitors. And unless I'm missing something, I know the competing product, ziftomenib, actually 2 ASHs ago, we saw that subgroup analysis that among patients who developed DS, differentiation syndrome, they were more likely to respond. It was like 75%. I haven't seen that for this data set just yet, but perhaps I'm missing something. And then QTC prolongation, which again has gotten some press in this class of agents, but I would note at the bottom here that not a single patient discontinued because of these reasons. So getting to the meat of why this was a late-breaking abstract, you can see that fine, only 18% rate of CR is quite underwhelming, but again, the main goal for these patients is to get them to transplantation, which at most centers, our center included, is to not have patients be transplanted in active disease, get to less than 5% blasts. So we include not only CR/CRh like the FDA wants to, but also CRi, CRp, and just given that at this point there's really nothing else to offer the patient, I would include MLFS as being a true quote unquote response, but that's debated on the regulatory side. So composite remission, 44%. This is not underwhelming, including a decent proportion of patients who achieved an MRD negative CR or remission. MRD negativity in the salvage setting maybe doesn't hold as much weight, but still important to know from a correlative sense. Looking at some of the chosen subgroup analyses here in this forest plot, you can see that response wasn't really influenced by many factors here, or many variables. With the exception perhaps of patients that had more treatment-naive disease, which I haven't seen the overlap, but my suspicion is that these are patients who probably didn't get venetoclax in the frontline setting. And everything we know doesn't really work well after venetoclax, but that's speculation. Event-based endpoints, and again, reason why this is, I think, I wouldn't call it a quantum leap, but certainly a great step forward. Median time to remission, in this case, composite remission, CR/CRh, was less than 2 months with a median OS of 8 months. And I don't know if I have it here. Yeah, I wanted to call your attention back to what the prior curve looked like. Different populations, this is more real world. 8 months versus less than 90 days. This is a substantial difference. And I think we're going to wait for more long-term data to see how, maybe the middle and bottom swimmers, end up, and how many make it to transplant, and they can derive maybe some chance of cure, which in this case, you can see is only about 20% at most. We're only 18 months out. But suffice it to say, this is, I think, a substantive high impact trial that is of an oral monotherapy for a terrible treat disease,
And this product, I think, is poised for, an FDA approval this year. So with that, I think that's my last slide. I'm happy to entertain any questions after the rest of the panelists have gone. Should I introduce the next one?
Could I just ask one question?
Sure.
Or comment? One of the slides commented the range of lines of therapy. I was wondering what they were.
Sure. I don't know if we have the granular data. I mean, it's still kind of a small population. Generally beyond 3 and 4, you're talking clinical trial. We can always offer something, but there is a point of, limited to no return beyond, 4 or 5 lines, especially post-venetoclax failure. Up to half for patients, yes. So with that, there's no timer, sorry. It's my pleasure to introduce Dr. Jan Beversdorf. We got a little bit on his background. Dr. Beversdorf initially trained in Germany, then was one of our outstanding, if not legendary, truly stuff of legends, residents at Yale. Bittersweet to see him go to Sloan Kettering, where he's completing his fellowship. But we are, in no small terms, thrilled that he's returning as faculty in less than 100 days. So with that, Dr. Beversdorf.
Thank you very much, Dr. Shallows. Let me just see if I can. Oops, no, let's just do. Thank you very much for the kind introduction. Thanks for having me. I'm still a fellow at Sloan Kettering, but I'm very delighted to return to Yale in July. We're joining the leukemia group, and I'm pleased to give an update today on myeloproliferative neoplasms based on recent data presented at the ASH annual meeting. Obligatory disclosure slide. I have no conflict of interest to disclose, no off-label drug use will be discussed in this presentation. So having to focus on just a few abstracts was actually quite difficult this time on this prior presentation, ASH on MPNs. And I picked 3 abstracts on myelofibrosis and 1 abstract on polycythemia vera for discussion today. And to put all of those a little bit more into context and to get everyone on the same page, I want to take a moment to review the current treatment landscape of patients with myelofibrosis. In general, there are various risk stratification tools that we apply in clinic, focusing on the degree of cytopenia, cytogenetic and molecular disease characteristics, but also importantly, spleen volume as well as symptom burden. And still to this day, the only potentially curative therapeutic modality for myelofibrosis is an allogeneic stem cell transplant. And eligible patients should certainly be strongly considered for this early on during their disease course. For patients who are not primarily transplant candidates, but have significant symptom burden and spleen volume, treatment with ruxolitinib and fedratinib, both are JAK2 inhibitors, is currently a category 1 recommendation by the NCCN. For patients with thrombocytopenia with platelet count of less than 50, pacritinib is a good choice. And then lastly, we also saw the approval of momelotinib, which is especially effective for patients with anemia related to myelofibrosis. However, this treatment paradigm might be changing soon. And we saw 2 presentations at ASH based on randomized phase 3 placebo-controlled trials of ruxolitinib-based combination therapies. And the first one I would like to discuss is the combination of pelabresib, which is a BET inhibitor, in combination with ruxolitinib in patients who are treatment naive with higher risk myelofibrosis, and that was the MANIFEST-2 trial. This is the study design of the trial. As you can see, 430 patients with JAK inhibitor naive myelofibrosis were randomized 1-to-1 to either ruxolitinib plus pelabresib or ruxolitinib plus placebo, with the primary endpoint being spleen volume reduction of at least 35% at week 24, which is the standard regulatory endpoint that has been accepted by the FDA. Key secondary endpoints included symptom improvement, and that's traditionally measured by a total symptom score or TSS. And yeah, this is the primary endpoint analysis. So the main takeaway from this is that the MANIFEST-2 trial achieved its primary endpoint with a SVR35 rate of about 66% in the experimental combination therapy arm versus 35% with ruxolitinib alone, and that was highly statistically significantly different. However, in terms of symptom burden, there were both secondary endpoints were technically not met. However, the total symptom score was borderline significant. If we look at the absolute change, there was a trend towards improvement in the combination arm. However, if we look at the percentage of patients who achieved at least 50% reduction in their symptom score, there was no difference between both arms. And I think this is one of the more interesting secondary analysis too, when we look at hemoglobin response. Ruxolitinib alone has myelosuppressive side effects. And sometimes anemia can be a real issue when we start treatment for patients with myelofibrosis, some patients even requiring transfusions in the beginning. So it's interesting to note that the combination arm actually had a higher rate of hemoglobin response and less patients requiring blood cell transfusions compared to the combination to ruxolitinib monotherapy. And this is it's still debated in the field what actually constitutes disease modification in myelofibrosis. But one of the surrogate markers that has been proposed is changes in bone marrow fibrosis. And as you can see here, there was overall both less patients who had worsening of the reticulum fibrosis and a higher rate of patients who had improved reticulum fibrosis with the combination therapy arm. However, how this translates into leukemia progression or long-term outcomes still needs to be seen. In terms of side effects, the side effects were very comparable in both arms. Primarily myelosuppression was the main side effect. Otherwise, GI toxicity was most prominent. The only real difference was in rates of dysgeusia, which is something that we only saw essentially in a combination therapy arm. And with this, I would like to transition to a second abstract, which was a Transform-1 trial, very similar design. This time, the combination of navitoclax, which is a BCL-XL inhibitor in combination with ruxolitinib versus ruxolitinib plus placebo. Again, in untreated patients with myelofibrosis, 1-to-1 randomization as shown here, primary endpoint again being SVR35 and symptoms being the key secondary endpoint. Again, the primary endpoint was met. Numbers are very comparable to MANIFEST trial that we just discussed, about double the rate of SVR35 with the combination therapy. However, this time there was clearly no difference in symptom improvement between the combination arm and ruxolitinib alone, and about 40% of the patients had at least 50% reduction in their symptom burden, as you can see on the right-hand side of the slide. However, this is also something that is important to keep in mind here when we look at the treatment emergent adverse events. There was a significantly higher rate of thrombocytopenia, anemia, and neutropenia, also higher grade events with the combination therapy arm. And this also led to higher rates of treatment discontinuation and dose reduction with the combination therapy arm. And there were otherwise, the side effects were comparable, but this is certainly a much more myelosuppressive regimen. So we will see where this leads us. Both trials technically met their primary endpoint, but the symptom improvement was not met. So we'll see what the FDA thinks about those trials. And then finally, I just briefly wanted to plug an ongoing trial that we have here open at Yale, which is, again, a combination therapy arm versus ruxolitinib alone. This is a combination of ruxolitinib plus selinexor versus ruxolitinib plus placebo. And primary endpoints are, again, spleen volume and symptoms. And so we would love to see any referrals that you may have in your practice for this trial. And then briefly for the remainder of this talk, I just wanted to discuss one abstract on polycythemia vera, or PV for short. Treatment landscape hasn't really changed much for PV. Still, treatment being dichotomized into either lower risk versus higher risk patients based on age, as well as a prior history of thrombosis. And the goal remains reduction of thrombotic complications with aspirin, anti-hematocrit control, either with phlebotomy alone or in combination with cytoreductive therapy. We saw plenty of updates on ruxolitinib and interferon, but can't cover them today for time constraint reasons. I want to discuss the new kid on the block, which is rusfertide, which is a first-in-class hepcidin mimetic that may actually be coming to us soon. So this is an update from the phase 1/2 trial. That's a REVIVE trial. We saw 2-year follow-up data. And also then earlier this year, there was a final publication in the New England Journal of this trial. And just briefly to go over the trial design, this was a single-arm trial of patients with PV who were phlebotomy dependent. And they first were in an open label dose finding, dose escalation phase, which was then followed up by a randomized withdrawal period, where half of the patients stayed on rusfertide, the other half received placebo, and then this was followed up by an open label extension period. And so this is the primary endpoint analysis of this trial, and it is as you can see here, the primary endpoint defined in this trial was the percentage of patients who received rusfertide in the randomized withdrawal period and maintained hematocrit control without the need of for phlebotomies. And you can see 69% on the rusfertide arm maintained phlebotomy independence compared to 18% in a placebo arm. And this is a busy slide, and like have a cursor, but let me just quickly walk you through this. This is just a nice visualization how effective rusfertide actually is. And you can see on the left-hand side, every triangle is a phlebotomy. So heavily phlebotomy dependent patients, this is before the dose of rusfertide. And then while patients are on rusfertide, you see there's hardly any phlebotomies anymore. And then this is the randomized withdrawal period. You can see the phlebotomies are coming back. And then once rusfertide is resumed, the number of phlebotomies goes way down, showing that this is really an effective treatment, but it's an ongoing treatment and not a disease-modifying agent. So also symptom scores were improved across different domains. And then in terms of side effects, this was overall really well tolerated, primarily low-grade localized injection site reactions. And this is then really encouraging and led to the randomized phase 3 trial, the VERIFY trial, which we also participated in. And this is a placebo-controlled trial that has completed accrual recently, and we'll hopefully get the results in the next year. And so if this really holds true, then rusfertide can really be an effective treatment for phlebotomy-dependent patients and really avoids the long-term complications of iatrogenic iron deficiency from phlebotomies, and also avoids the hematocrit fluctuations that we see between phlebotomy sessions. So really exciting, but we'll obviously have to see the results from the phase 3 trial. And with this, I'll stop, and thank you very much for your attention.
Excellent presentation. All right, I think the prime rib is still warm. I feel bad if there's no prime rib, sorry. Our next speaker is Dr. Lourdes Mendez. Dr. Mendez originally trained in New York. She got her MD as well as her PhD from Einstein, then completed a residency at Cornell, and then completed her fellowship at Beth Israel in Boston, where she stayed on as faculty until about, I want to say 2 years ago, until she joined us with our leukemia group. And Dr. Mendez will be talking about the highlights regarding ALL.
Okay, so I think we all know that the treatment of pediatric ALL is a success story in oncology, but the treatment of adults with ALL has been a much greater challenge. And so I selected 3 abstracts for discussion today that focus on optimizing the treatment upfront of ALL. So these are my disclosures. And I'm going to start with B-ALL, discussing the frontline use of blinatumomab as reported in 2 abstracts at this ASH. But first, just to orient ourselves, at ASH 2022, Dr. Litzo presented in a late-breaking abstract the incorporation of blinatumomab into consolidation in newly diagnosed patients with Ph-negative B-ALL. And provided randomized data that for the first time extended the role of blinatumomab to the MRD negative setting, showing the impressive improvement in survival in these MRD negative patients, and thus arguably changing the standard of care in our field, and providing a role for blinatumomab in first remission. So at this year's ASH, the preliminary results of the GMAL BOLD trial were presented. And this trial focused on newly diagnosed older patients with Ph-negative B-ALL, studying blinatumomab in sequence with chemotherapy that was dose reduced. And so this is an overview of the treatment strategy. So a major goal, given the study population, which was older adults in ALL, this is adults that are greater than 55 years of age, which the historical experience has shown us is a very vulnerable group of patients with this disease who have had really suboptimal survival outcomes on the order of maybe 20% durable survival. So an area of great need. So a major focus of this treatment strategy was to de-intensify the treatment. And thus blinatumomab, shown in blue, was substituted for 3 of the chemotherapy segments in this treatment. In addition, the initial chemotherapy cycle compared to the historical backbone that this cooperative group has been studying was also scaled back. So a couple of changes compared to their historical backbone. The primary endpoint of the GMAL BOLD was to evaluate the rate of complete hematologic remission as compared to their historical experience. And a key secondary endpoint, as you might imagine, is to evaluate the molecular response, even that we know blinatumomab has a major role in deepening responses. So the primary endpoint of this trial was not met. There was not an improvement in the hematologic responses. After that first cycle of chemotherapy, there was greater than 70% hematologic remission. And so there was not a statistically significant improvement on that with the addition of blinatumomab. However, there was a very significant improvement in molecular response that was observed after 1 blinatumomab cycle. So 82%, a very robust number compared to 55%. And this seemed to translate into a benefit in outcomes. So what's shown on this slide is overall survival and remission duration at 3 years. The 3-year overall survival was 67%. Again, if we hearken back to the historical experience, the numbers are generally under 30%. And the 3-year disease-free survival was an impressive 83%. This is a single-arm study. And so what's shown on the graphs is in comparison to the group's historical experience in their GMAL registry. They also, in subgroup analysis, further stratified the survival outcomes by age. And there was a particularly marked benefit in patients aged 55 to 65 years of age, where the overall survival at 3 years was over 80%. So moving on now to the final results of the Jimema-Lal 2317 trial. So this was a different study group, so a similar question, the role of upfront blinatumomab. But this is a wider range of ages. This is not focused on older adults or on reducing the intensification of the treatment. And here the major focus is to improve minimal residual disease. So these treatment regimens, as I think everyone knows, are quite complex. This is the schematic of the treatment plan. A major point is that here blinatumomab is not substituting for chemotherapy cycles. It's superimposed on the existing backbone that was previously being used. Here, the median age of the patients is 40. Ranging from 18 to 65 years of age. And the MRD time points, which we're going to talk about, the initial ones are after the first cycle of chemotherapy. And then the second one is after the second cycle of consolidation, right before blinatumomab. And then, of course, there is an MRD time point after the first cycle of blinatumomab. And the primary objective was to discern if there was an improvement in the rate of early MRD. So this time point 3 MRD data point. So this study did meet its primary endpoint. The MRD negativity rate after one cycle of blinatumomab was 93%. And that was an improvement over 72% prior to blinatumomab. And on the right, the graph, you can see the MRD positive patients prior to blinatumomab moving up to join the MRD negative patients. An interesting subgroup analysis, there was no difference in MRD negative rates by age group. So all age groups benefited. On the other hand, the very high risk group, which was defined by white blood cell count and by high risk cytogenetics, did not have an equal MRD negativity rate. So some suggestion there of a difference. So these are the outcomes: overall survival on the left, disease-free survival on the right at the 3-year time point. 71% and 65%. So if we focus on the right and the subgroup analysis, there was no statistically significant difference in disease-free survival according to risk group. So all risk groups seemed to benefit. There was also no statistically significant difference in disease-free survival by age, although there was a trend down from 70% in the younger patients to 51% disease-free survival in the older patients. So highlighted on your left is overall survival by age. And there was a statistically significant difference. There was inferior survival in patients greater than 55 years of age with a 3-year overall survival of 51%. So suggesting that one way to interpret this data is that the patients who are benefiting here are those who are 40 to 55 years of age, in particular from the modification and the introduction of blinatumomab superimposed on the prior treatment plan. So this study took a close look at PH-like BALL, which we know is a particularly high-risk subgroup of pH-negative BALL. And it was quite interesting what they found. In the table is reported the results of the MRD studies. So after one cycle of blinatumomab, 100% were MRD negative. And yet, if you look at the outcomes, and on the right in particular, showing disease-free survival, the PH-like group has a 42% disease-free survival compared to 75%. So that MRD negative rate did not translate into the same level of disease-free survival at all. Which is, you know, a point that one could spend some time reflecting on. And so, you know, to summarize, relapses were enriched in pH-like B-ALL. For anyone who has a particular interest in ALL, these were CRLF2 rearranged pH-like B-ALL and JAK-STAT rearranged B-ALL that were enriched in these relapses. So switching gears now to T-ALL. To summarize the prior two abstracts before moving on, what we found was more evidence, more data supporting the role for blinatumomab in first remission. So the use of blinatumomab frontline. So here we're only going to discuss one abstract. So just to remind ourselves, Nelarabine is approved for relapsed refractory T-ALL, and it's also been studied frontline. It's been studied on the top, frontline by the MD Anderson group, who have added it to hyper-CVAD. What you can see is lines that are essentially superimposable on the top two of the four. So there was no improvement in outcomes. In a more recent study, they did report in blue in the text that in subgroup analysis, there seemed to be a benefit in the non-ETP phenotype T-ALL, but not in the ETP phenotype T-ALL, which we know is a very high-risk group. The Children's Oncology Group in the seminal ALL 0434 also studied the role of Nelarabine as part of treatment in intermediate risk and high risk pediatric ranging to 31 year of age subjects. And you can see on the right that there was a substantial improvement in the rate of CNS relapses, and there was also an improvement in disease-free survival in this age group with the incorporation of Nelarabine into treatment. And so at this year's ASH, the GRAL group reported the results of their studies in adult patients with the incorporation of Nelarabine into consolidation for high-risk T-ALL patients. And just to provide a little background on how they define these high-risk patients, in their previous GRAL 2005 study, they had identified a high-risk population that had an overall survival at 5 years of 52.9% versus 84.9%. And this high-risk group could be defined or identified in one of two ways, which is highlighted in the text in red: end of induction MRD greater than 1 in 10,000, or a specific genetic signature, which is the absence of mutations in a Notch1 pathway or the presence of RAS P10 mutations. And so they, in their next iteration of investigation, focused on this high-risk subgroup of T-ALL. And they did so using a nested sub-study within their GRAL 2014 trial. So to summarize the findings from this trial and then show you some of the data, Nelarabine as part of consolidation for these high-risk adult T-ALLs did lead to deeper responses, but again, this did not translate into improved outcomes in terms of disease-free survival and overall survival. Subgroup analysis did once again suggest that perhaps deeper responses may translate into improved outcomes for a subgroup, a subset of patients. And just to spend one moment to explain the treatment strategy here, what the graph is showing you, if you focus on the right side, is that the patients received induction. They received a consolidation cycle, and then with the second consolidation cycle, Nelarabine was incorporated, superimposed on their prior treatment regimen, which is important because that's part of how they do their comparison. Patients who met criteria to go to allogeneic stem cell transplant received 1 consolidation cycle containing nelarabine. Patients who were not going to transplant received 2 nelarabine containing consolidation cycles and 3 maintenance cycles that contained nelarabine. So this cycle is focused on the MRD responses with the incorporation of nelarabine, which I think is probably easiest to see graphically. So on the left, we have the use of nelarabine. On the right, no nelarabine. The patients who did not get nelarabine are patients within the same trial before they opened the atrial substudy. And the dark blue shows MRD negative patients. And you can see that at the 3rd time point, the dark blue substantially increases. And these are patients who have now received nelarabine. And if you compare the dark blue part of the graph on the left and on the right, you can see how nelarabine led to deeper responses. And this was statistically significant if you considered patients who were MRD positive after the first cycle of treatment. Highlighted in yellow is what I mentioned before, which is that this did not translate into any statistically significant difference in disease-free survival or overall survival. A little bit difficult, I think, to focus on, but within this table is a sub-study analysis that tries to highlight that there was a significant reduction in the cumulative incidence of relapse if you censored on stem cell transplant, so the patients who did not go to transplant. And further subgroup analysis focused on this very high-risk ETP phenotype versus the non-ETP. And in this subgroup analysis, if you focus on the right, there seemed to be a statistically significant improvement in the cumulative incidence of relapse, as well as in disease-free survival for the non-ETP group, which is consistent with previously published subgroup analysis by the MD Anderson group. But basically, no overall survival and no disease-free survival that could be eked out in terms of the main analysis, only in subgroup analysis. And so arguably, there would be a need for additional prospective data to guide the incorporation of nelarabine in patients who are 31 years and older. So that concludes the 3rd abstract. I think what we can take away is that the novel agent blinatumomab really has become the standard of care in consolidation, to the point where now it's being investigated and being brought forward even earlier as part of induction in ongoing trials. And I'm happy to take any questions.
All right, these abstracts are open for discussion. Hungry. All right.
Can you define ETP for the TLO? I mean, it's not really familiar.
Sure. We define it using flow cytometry. And it's characterized by the presence of biomarker markers. And it's important to identify it because it's a high-risk subgroup of TALL that we try to take to allogeneic stem cell transplant.
Thank you. So Michael, I have a question actually for Rory. This question is in patients who have low risk MDS, and we're talking about luspatercept versus the newer agents, the elritercept. Do those, which one would you say, and I know there's not a comparison, but if you have a patient that you're thinking of starting on luspatercept, can you wait until the newer agent came out? And the other question is, is there some crosstalk for patients who are demonstrating both anemia and thrombocytopenia? Is there some improvement in thrombocytopenia and use of those agents, and just one, which is one in that type of
Sure, that's the golden question, I guess. And you're right. It's hard to derive any meaningful conclusion without truly randomized data with a head-to-head comparison. Luspatercept is without a doubt furthest along, and this is maybe the difficulty for this quote-unquote competing product. Getting, I guess, the question 1B, I would suspect there'd be limited, if any, response with this, quote unquote, second generation of luspatercept people now after luspatercept exposure / failure. They generally have the same MOA. That's the hypothesis, at least. So, not something I would be enthused with, especially when we have other reasonable second / third line options for low risk MDS. Lenalidomide is still available, even outside of non-del(5q). This is, I think, under-recognized. And getting to question, I guess, 1C, with concomitant thrombocytopenia, it really depends on the depth. Is this clinically actionable to the point where the patient is at bleeding risk, usually less than 50 with a structural reason required, or less than 10 for spontaneous hemorrhage? Those are probably patients that maybe shouldn't be prioritizing a largely anemia-directed therapy like these EMAs. So probably more consideration for quote unquote low dose HMA like oldacitabine, for instance. Question 1B, about 20% of patients on that specific trial did have baseline thrombocytopenia. I forget the grades. There was some evidence that yes, they did have some improvement in platelet count, but again, I would argue it's just a quantitative and not really a clinically meaningful increase. This data has been available for luspatercept as well, and a subsequent publication based on the post hoc analysis. And fine, there are probably some other effects. I mean, my second slide kind of was a kind of visually described this a little bit, but that could be just a quote unquote added quantitative benefit that has no, in my opinion, a meaningful clinical benefit.
One other question for Jan. Thank you again for that excellent presentation. In our patients with myeloproliferative disorders, we often see both some polycythemia vera and some essential thrombocytosis associated with it. And these are the folks that I have the most difficulty with in terms of you may have a reactive thrombocytosis while you're holding the iron. And you'd love to give a little bit of iron just to see if you can get the platelet count down. And if you're thinking how much of the platelet count is elevated because of the low iron state, as opposed to the essential thrombocytosis outside of it. So these mixed pictures that give me the most angst and staring up at the ceiling in the middle of the night, trying to figure out where am I going with this.
I share your that certainly keeps me up at night too. But yeah, no, this is a clinical dilemma that we face a lot, and you can see even like that ET sometimes even transforms into PV. It is sometimes really difficult to tease out if someone is severely iron deficient, ferritin in the single digits, restless legs, the hematocrit is like, it's sometimes difficult to really tease us out, but sometimes we do give a little bit of iron, maybe so. But I think in that case, rusfertide is a great option actually, if this becomes available, because it is actually doesn't cause systemic iron deficiency. It really interacts with how iron is being metabolized in the bone marrow itself, how it's being incorporated into red cells. And I think that can be then like an effective option for PV patients where you're already like battling with iron deficiency, for sure.
What I've been telling my patients is eat 3 to 4 portions of red meat a week. Right. Bigger portion the better.
Yeah, absolutely. I would not give IV iron probably, but I think that's yeah.
Concludes our morning session. Really wonderful speakers, and kudos to all the presenters. Thank you very much. And I think this is very nice thematic transition from your last comment, Dr. Farrell, to take a break for lunch for 45 minutes, and we will resume our presentations at She also serves as a director for DeLuca Center for Innovations and Research in Hematology at Yale Cancer Center. Additionally, she also leads as a co-director of Clinical Research Support Lab at Yale. As you all know, Dr. Helena completed her medical training at Yale, both medicine residency as well as hematology, oncology training, as well as research training, and joined the faculty at Yale in 2008. I think this was around when I was a second-year fellow in this program too. And since then, she has really risen through ranks and has developed an amazing research laboratory. She's well-funded and has been really internationally and nationally renowned for her work in MDS and leukemia. She's particularly famous for her work in developing mouse xenotransplantation models to study these diseases, and these models have enabled researchers to study novel therapies for MDS and AML in this context. Since her tenure as a chief of hematology, we've really witnessed tremendous growth of the section of hematology, and we really owe so much to her leadership at this time. You can see all of our speakers, all of our growing disease teams that have delivered delightful presentations today, very, very encouraging, and we're seeing growth and tremendous progress on all fronts and all domains of hematology, from clinical care expansion as well as basic science research, for further recruitments in that area, as well as clinical trials and outcomes type of research. So I'm delighted to introduce you, and we're looking forward to your talk describing RNA biology and myeloid disorders. Thank you.
All right. Natalia, thank you so much for this really, really amazing introduction. When Natalia asked me to give this talk, I said like, yeah, sure, but really, do you really want a basic scientist? And then it also turns out I'm on service. So I'm really, really proud to be covering the service while the fantastic faculty are giving these talks. So the first two slides are the most important ones, and then the rest is a lot of basic science. So, you know, postprandial, if you need to take a nap, enjoy. So I'll give you a little bit of a tour de force, but okay, the third slide. So I have a couple of disclosures. So I've research support by Storm Therapeutics and AstraZeneca, just agents we use in the lab. So this is really what I'm super, super, super proud of. This slide, you know, has grown. I hope I didn't forget any pictures, but we have so many fantastic faculty like Natalia and others who have stayed here through all the good and hard times, always taking care of patients, and really build a reputation and build this section in the Cancer Center that then has welcomed so many junior faculty now who are stellar and bringing amazing expertise from, you know, genomics and thrombosis, endothelial cells, and ALL and splicing and so on. So the expertise here at Yale is fantastic. And I'm so happy, and maybe next time we do this, I need 2 slides. We really also want to congratulate Amr for his new position as a division chief of malignant hematology, and Alfred has already led classical hematology to really amazing heights. And then, you know, right, and that's you know, we always thought, okay, Central New Haven, that's where the expertise is, but that's of course not true. We are covering a lot of Connecticut with absolutely fantastic doctors. And I'm seeing here Smiler Network hematology focused. And yes, some of our wonderful colleagues, Francesca, Kelsey, Catherine, David Witt, and others are really hematology focused, but everybody at every Smiler site is seeing a lot of hematology because we have many patients. And the expertise is really shared across the entire network. So again, thank you to all physicians everywhere who are providing such amazing care, and it's always a partnership. And then, yes, we're always so physician-centric. Of course, behind every physician is a most amazing team of advanced practice providers, practice nurses, people running the clinic, schedulers. So really, I want to really highlight what an amazing team we have in hematology and Smilo. Okay, so let me just you know, give you now a little bit of the side talk. So my lab is particularly interested in myelodysplastic syndromes. You're the experts here in the room, but the incidence is growing, right? As our population ages, it's growing in further. And it's caused by genetic, epigenetic, transcription, signaling, and splicing operations. And we always think about MDS progressing to AML as the worst thing, but of course we also know that our patients are cytopenic and suffer from infections, bleeding, and quality of life suffers when our patients are this ill. I'm not going to go into this, but it's a hematopoietic stem cell disorder, so that's really the cell we need to get at. Of course, when somebody is older, do they still have normal stem cells that we could rescue? In about 2000, right, so this is just showing the frequency of the different classes of mutations that patients that cause a disease. In about 2011, which seems ages ago now, these splicing factor mutations were discovered, which occur in more than 50% of patients. And that's kind of when I also started my laboratory, and we became particularly interested in the RNA biology of it. So, right, so these splicing factor mutations, they were discovered in 2011. Really international effort. I would say the main paper that broke around ASH came from a Japanese group, Seishigawa, showing that these splicing factors, which are really the key factors in the spliceosome, are mutated. And I think they probably showed up in testing before, but nobody thought that that could be real because they're so essential to cellular function. These mutations occur in over 50% of patients with MDS and CMML, and about 20% of patients with secondary AML, but then also in patients with CLL and high-risk clonal hematopoiesis and also some solid tumors, actually. What's interesting is that they are mutually exclusive. So in generally, any patient has only one of these mutations. And maybe if they have more than one, it's probably an independent clones. The variant frequency is high, so about 40 to 50%. And since these are heterozygous mutations, that means they're really in the dominant clone. So when we sequence patients, it's always kind of very high percentage, and we still know that these are driver mutations driving the disease. Splicing is a really fundamental process, right? So you have the genome with exons and introns, and these transcripts have to be processed. So you have to remove the introns, splice the exons together. The RNA has to then capped, polyadenylated, exported, and then to be transplanted to proteins. And alternative splicing, when it's healthy, actually really provides a really large diversity of the proteome. So it's important. But when splicing goes wrong, then of course, now there are abnormal proteins or proteins are not made because the message is degraded. What is interesting is that in these splicing factors, the mutations are hotspot mutations, meaning they're occurring at very specific amino acids. They're obligatory heterozygous, so the cells require one wild type allele or they die. And we consider them gain of function mutations because these proteins now are not just loss of function, meaning they're just like not there, but they're gaining new aberrant functions where that they contribute to the disease. So over the years, we really have learned that these different splicing factors and mutations, they really define clinical phenotypes. So SF3B1 mutations, for example, are really pathognomonic for MDS with sideroblasts. But interestingly, they also occur in CLL. While as in MDS-RS, they're good prognosis. In CLL, they're probably a worse prognosis. They also occur in uveal melanoma, right? So there's still a lot for us to study of why is this occurring. Mutations in U2AF1 recur in MDS. They also occur in lung cancer. And mutations in SRSF2 occur in MDS, and particularly in CMML, and really high percentage of patients with chronic myelomonocytic leukemia. This just shows again, how frequent these splicing factor mutations are. So you see that SF3B1 is very, very common. And this again, it's an old slide, so it's the old MDS classification, but SF3B1 mutations occur predominantly in MDS with ring sideroblasts. Then you can see again SRSF2, U2F1, and even ZRSF2, which I'm not talking much about. So a lot of labs have then taken patient samples and sequenced these samples and then looked at, okay, what genes are downregulated, what genes are differentially spliced. In SF3B1, it makes sense that aberrantly spliced genes include a whole bunch of genes that are important in iron transport. So you have ring sideroblasts. In SSF2, those genes are epigenetic regulators, EZH2, INS3, in U2AF1, again, a whole bunch of genes. What you notice is that there is some overlap between the different splicing factor mutations, but not a ton, right? So the mutations occur in specific disease phenotypes, but then why are they all causing MDS, right? So there's still a lot we have to learn to understand, well, why does the mutant stem cell actually survive and take over? And those are ongoing studies. So my lab early on got interested in studying RNA biology, and then these splicing factor mutations were described, so we jumped on that. Since then, we've also worked on RNA modifications. I'll give you just a little taste of that. So, so we initially just asked, well, these mutations in SRSF2, how do they actually change RNA binding? And now it gets, so if you need to take a nap or digest or so, now the time's getting a little bit basic. But SRSF2 recognizes so-called exonic splicing enhancers in the exon. And this whole complex refines the 3' splice site to decide, well, where is the boundary between the exon and the intron, right? And here's the 5' splice site. And so SRSF2 recognizes so-called exonic splicing enhancers, and then it decides, what is this exon going to be included or excluded, right? And exons ultimately contribute to protein coding. And so what was very interesting, so SRSF, this is the kind of, the sequence of SRSF2, it has a canonical RNA binding domain, and then he has kind of like these two N and C terminal arms and a so-called SR domain, which interacts with other proteins. And when we started studying this protein, it was really unclear what mutations, and this people called it the linker region between the RNA binding domain and the SR domain. Like, how could that lead to alternative splicing? And then you don't need to look at this, but this is kind of like the structure of SRSF2, this N-terminal RM and C-terminal domain in the free form. And this is when RNA is bound. And you can see that these linkers or arms actually grab the RNA. So you can now imagine that if there's a mutation in this region, that it could change RNA binding. And that's what's shown here. So SRSF2 binds CCNG or GGNG, and the mutant protein has just different binding affinities. And then when we then sequence and do additional testing, that essentially means that if there is an exon that has a CCNG exonic splicing enhancer, the exon gets included. But if it's a GGNG, then it gets excluded. So you can now imagine that now we have aberrant proteins, or actually something that we call poison exons. So there can be premature stop codons that then result in degradation of the message, no protein. And back then, we then teamed up with Omar Abdelwahab at Sloan Kettering, Rob Bradley at the Hutch, who had developed a mouse model and found the same, essentially the same, where wild type SRSF2 binds GGNG or CCNG equally well, but the mutant binds CCNG. And one of the important messages that is aberrantly spliced and then degraded is EZH2. Right, in lymphoma, there are EZH2 inhibitors. In MDS, loss of EZH2 is also something contributing to MDS phenotypes. So SRSF2 essentially leads to aberrant splicing of EZH2, decreased protein, and that contributes to MDS. And then when we sequence patients, we don't see SRSF2 or EZH2 mutations in the same cell because now the message is already gone, so it doesn't have to be mutant. So then, right, if you think about splicing factor mutations, and this is something that we know from mouse models, right, the cell is healthy if you have two wild type alleles. And if you knock out one allele in the mouse, they're essentially fine. So one wild type allele is okay. If you have one wild type, one mutant allele, you have now disease, clonal hematopoiesis, or MDS. And then if in the mice, you now have only one mutant allele and you get rid of the wild type allele, the cells die. So this could be a therapeutic approach. Alternatively, could you somehow get rid of the mutant allele or its effect? And maybe you have a rescued phenotype with a minimal phenotype. And so can splicing inhibitors mimic the mutant hemizygous state? So early on, when we studied splicing factor mutation, this was incredibly exciting and then very disappointing. So as you see here, so I'm not going through this, but this is really still a simplified version of the entire splicing complex. And all the mutations are early on at the time of definition of the 3' splice site. And then you see here, right, here's SF3B1. And so long time ago, people studied actually SF3B1 inhibitors in solid tumors, and then they They had toxicity, blindness, they were never pursued, but then it seemed very attractive to pursue SF3B1 inhibitors, potentially in the treatment of splicing factor mutant MDS. And in the mouse models, it looked amazing. It went into clinical trial, and unfortunately, it did not work. So it didn't have splicing factor mutant specific signature. And I think we all hope that somehow this is going to get revived, but currently this drug is not available, neither for research or limited for research or in clinical trials. So are there other avenues to approach splicing factor mutant MDS? Again, I'm just summarizing this briefly, but PRMT5 phosphorylates other splicing factors. So there are PRMT5 inhibitors that I think are in clinical trials. There's some research again from Omar Abdel Wahab's lab on RBM, another RNA binding protein, so RBM39. And could there be degraders and also specifically target splicing factor mutant MDS? So those are kind of like in gray because we don't have particularly good data or they're not in clinical trials yet. I think a study that's incredibly exciting, coming through a lot of work from Dan Straczynowski's lab at Cincinnati Children's Hospital, and there's a recent really exciting ASH abstract. And what Dan identified initially in U2AF1 mutant MDS, that this protein IRAK4 is differentially spliced. And now you get so-called IRAK4 long isoform, and this IRAK4 long isoform results in aberrant activation of NF-kappa B, so inflammation. And they ultimately also found the same splicing aberration in SF3B1 mutant MDS and have since developed IRAK4 inhibitors. So my understanding is that if you inhibit only IRAK4, right, that's the problem we have in cancer in general. If you inhibit one pathway, the cells will always find another way. So currently, I think, or there will be soon, clinical trials involving dual IRAK1, IRAK4 inhibitors going into clinical trials for splicing factor mutant MDS AML, but maybe also AML in general, because we always think about inflammation as a driver for leukemia, especially if we think about it as a disease of aging. Also, there's other interesting, really interesting work from Tim Graubert and Shandong Fu. And again, right, so splicing co-occurs, so co-transcriptionally. So this is all very complicated basic science, but essentially as the RNA is transcribed, it's also spliced. And the idea is if it isn't spliced, suddenly this RNA or this intron can actually form so-called R loops, meaning the RNA binds with the DNA, and now you have a free strand of DNA, and then you have this RNA-DNA hybrid that can cause R loops. And then if the cell also replicates at the same time, you now get this replication stress and activation of ATR and CHEK1. And so the Dana-Farber Masterno group are actually testing ATR inhibitors, again, as a splicing factor mutant specific approach, and have some interesting results, I think, in their clinical trial. Another group, so Stan Lee and Haidang Yan, Stan Lee was in Omar's lab, also looked at R loops and looked at, again, this activation of DNA damage response, and found that maybe PARP inhibition could also kind of function as a synthetic lethality in splicing factor mutant MDS and AML. So this is a very recent science paper, so in the basic literature, so we will have to see if that could be a viable approach for treatment. So then I'm just summarizing here again, so we can kind of target this wild type effect. Maybe PRMT5 inhibitors, IRAK4 or IRAK4 and 1 inhibitors, ATR inhibitors, maybe PARP inhibitors. But could we also potentially specifically target the mutant splicing factor effect? And now I'm going to go back a little bit to the basic science we're doing in the lab, where, right, so if we understand how these splicing factors bind to RNA, could we potentially directly inhibit the mutant binding versus the wild type binding? And I think what's very, very interesting in RNA science that, right, we always thought, okay, nuclei or proteins in the nucleus were undruggable. We always thought that maybe protein-RNA interactions are not directly druggable. But there's, I think, really interesting science coming out where you could potentially find a small molecule to disrupt maybe mutant splicing factor binding to RNA and keep the wild type binding intact. And so for this study, we focused on U2AF1. And again, U2AF1 binds really at this AG at the 3' splice site. But that has never been shown in vivo. And again, the mutations occur in a strange location, right? Here's kind of the homology domain. And then here are two zinc fingers domain. And these mutations in U2F1 occur in the first zinc finger and second zinc finger as S34FY or Q157ROP. And what a structural biology paper has shown that actually these two zinc fingers end up lying next to each other, and they're actually forming the RNA binding domain. So clearly, again, these mutations affect directly RNA binding. So there is a very complicated technology called enhanced cross-linking and immunoprecipitation. So we take cells that have either wild-type or mutant splicing factor. We UV cross-link the proteins to the RNA. And then we pull out the protein, and with the protein, we pull out the RNA. We can then label the RNA with radioactivity and run it on a gel. And then we send everything for sequencing, and then we sequence, and then where these reads in next generation sequencing end, that is actually the binding this cross-link site. So we can look at binding of these proteins essentially in vivo. This is shown here. So here's U2AF1. And U2F1 always forms a dimer with U2AF2, and U2F1 binds the 3' splice sites, U2F2 binds the so-called polypyrimidine tract. What you see here is essentially radioactively labeled RNA run on a gel. Here are probably the U2F1 RNA binding complexes, and we can't, these two don't come apart. So up here, we probably have U2F1, U2AF dimers binding the RNA. This is then what this looks like bioinformatically, right? So here at the bottom, you see the exon, the 3' splice site, the intron. And here now in these curves, you see essentially the frequency of these cross-link sites. And this is really for the first time that it has been shown in vivo that U2F1 really binds at this 3' splice site. And then here you see the U2F2 peak over the polypyrimidine tract. And then we can ask, well, how do these mutations change binding of the mutant RNA binding proteins? And in orange, you see the S34F mutation, and you can see that there is an extra peak at the -3 site. And then up here, you could see that it also seems that these mutations not only alter how U2F1, the mutant protein, binds, but they also seem to affect how U2F2 binds. And then in blue, you see the curve for the Q157R mutation, and you can see that there's a gain at +1, counting at the 3' splice site. And again, even in the blue curve, you can see that, the whole complex binding is now changed. And U2F1, U2F2 really are the ones to determine, okay, this is the 3' splice sites. This is where you now need to cut this intron and then, essentially glue the exons back together. And so now the question is, okay, if we see this binding in vivo, does it really translate into how then exons are spliced? And so this was already known from patient cells, but if you look at, the exons that are either included or excluded, up here, and you look at, okay, does a sequence at the 3' splice site change? You can see that exons that are excluded have a predominance of U at the -3 site, and exons that are included or excluded with the Q157R mutation have a predominance of A. So this -3 site and +1 site that are differentially bound are also determining how these exons are spliced. So this is very basic. So if you made it through this, you're good. So then, right, we can now look at differential binding. Like, what are those genes? We can look at differential splicing. What are those genes? We can combine those so that we have a direct signature of what these mutant proteins may be doing, rather than, right, the moment you change something in the cell, you always have secondary changes. And then we can look at, well, what is the signature? What are these genes? Where, what cellular function do they determine? And then the interesting thing that we found, we were very excited, is that there seems to be a so-called stress granule signature. So what are stress granules? So we're all stressed. So, this is going on in our body, but they're good. So they're so-called biomolecular condensates in the cells, right? So all cells, nuclei, they all have membranes, but to really affect changes quickly, proteins and RNA in the cell, they can gel and they can ungel. So, the cell can respond very, very quickly to any kind of challenges, damage or lack of nutrients, etc., and then can pull proteins and RNAs into these granules, take them away from, for example, the translation machinery, and then when the stress resolves, can release those proteins again. And so these are really, there's no membrane, and it's really proteins, RNAs forming these gel-like structures. And, and again, cancer cells are smart, so unfortunately, and they can exploit these mechanisms. So there's definitely been a description of enhanced stress granule formation in cancer cells. So if we have the signature, does this really happen in the cells? And that's what you're seeing here. So these are cell lines that express the wild type of mutant splicing factor, and then are stressed with arsenic, so oxidative stress. And what you can see is that these are, the colors are not so great here, but these are wild type stress cells. You don't see any red. These are the different mutant stress cells. And you can see now that they have actually a lot of stress granules. And it could be, right, that they are now gaining potentially proliferative advantage or could survive better in the bone marrow. And then these are cell lines. You never know what they do. And so these are now actually primary patient cells that are either wild type or mutant for U2F1 and also have. So we see this in primary cells, that there are increased stress granules. So can we do something about it? Not yet, but maybe in the future. And so there are actually so-called inhibitors of the integrated stress response, or called ISRIP. So this may be an opportunity, right? Could we treat patients with these inhibitors, and would then these mutant cells no longer have the clonal advantage over wild type cells? Again, this is done in cell lines in the laboratory, where it's looking at cell survival. And if we treat these cells with this, either with arsenate to stress them and then ISRIP, there is a decrease in their survival advantage. So I'm putting a big question mark, is maybe one future therapeutic opportunity to inhibit these stress granules. And, and maybe what I want to point out, so we often think about, MDS, right? That's where we start treatment. But of course, these mutations also occur in people who are otherwise healthy in the form of clonal hematopoiesis or clonal cytopenias of unknown significance. And in general, splicing-affecting mutations are regarded as worse prognosis, more likely progression to MDS, AML. So maybe with all these treatments, we have opportunities to intervene sooner. I just want to show a quick, quick slide again from last year's ASH, and I was super delighted of being allowed to introduce this plenary talk by Salima Bembashi and Omar Abdel Wahab's lab. So definitely worth looking at the abstract. I'll try and summarize it quickly. What Omar's lab has done is that they looked at all these recurrent splicing events, and then they identified in SF3B1 mutant cells, and then they identified the key sequence in the intron that determines whether that intron is now retained or spliced out. And they put that piece of intron in the middle of a fluorescent gene, and then they can put these reporters into cells, and then can really read out with a fluorescent signature and flow cytometry whether splicing is aberrant or corrected. And then they did a so-called CRISPR screen, genome-wide CRISPR screen, knocking out all sorts of genes, right? And then looked at, okay, are there any genes that if we knock them out, we now get rescue correction of the splicing in the mutant context? And they found this gene GPatch8. And I'm not going to give you too much detail on this, but essentially, SF3B1 binds in the intronic sequence, and it has to interact with a lot of different proteins or helicases, right, that then help cut the RNA, for example. And it seems that GPatch8 gets into the way of DHX15, another helicase, in the mutant setting. And if they now get rid of GPatch8, now the mutant protein no longer aberrantly splices the RNA, but finds actually the proper site in the intron. And again, this is from the abstract that's published. And then, right, so what they then do, they have mouse models with the different SF3B1 mutations, and they can just knock out GPatch8, and they can then show that you actually get rescue when you knock out GPatch8 of erythroid colonies. And this is also what they're showing here, I think, with human iPS cells, that if you knock out GPatch8, you now get erythropoiesis. Obviously, there are no drugs targeting GPatch8, but that's what Omar's lab is working on now. So that could be exciting if you have somebody with S3B1 mutation, S3B1 mutant MDS with ring sideroblasts, maybe you don't need to kill the stem cell. You just need to correct the erythropoietic phenotype. Then patients no longer have anemia and they have quality of life, right? Because patients with MDSRS can live for a very long time. So I've told you a lot about RNA, and I've told you a lot about splicing, right? So where introns are removed, exons spliced together to get the proper proteins. There's a lot of processing going on. And one of the very, very interesting fields right now is really RNA modifications, right? For the longest time, we've always focused on DNA methylation, right? We're using hypomethylating agents. We're focused on proteins, tyrosine kinase inhibitors. Now really is, I think, the decade or whatever for the RNA world. And RNA modifications, so the most common one is actually M6A methylation of RNA. And there are writers. So META3 is one of the META3/META14 complex, one of the writers of this M6A methylation. And then there are erasers, ASH5 and FTO. And then this M6A mark is actually get read by so-called readers in the cytoplasm or in the nucleus, and these readers decide what happens to the message. Is it going to get translated, so you're going to have more protein? Is it going to get degraded, so you have less protein? So on top of just how much RNA is there, there's a whole other layer of RNA stability or translation to determine levels. And it turns out that META3 or META14, for example, are upregulated in AML. ALK-BH5 and FTO are both inhibited by 2-hydroxybutyrate, which is the oncometabolite produced by mutant IDH1 and IDH2. So again, all these epigenetic regulators that are mutated are again tightly, they have a lot of downstream effects, for example, on RNA modifications. And because of this link to IDH mutations and to hydroxybutyrate, we started studying RNA modifications in the lab. And I won't show much of that, but we identified that if META3 is actually knocked out, you get double-strand RNAs and an native immune response in cells that could potentially be harnessed in conjunction with immunotherapy. And ALK-BH5 deletion, for example, causes a defect in energy metabolism in cells. What's very exciting, while we were studying M6A RNA modification in the lab, a group in Cambridge actually developed small molecule inhibitors of META3. This is one of the two compounds, STM245, which is highly selective, and it inhibits M6A RNA methylation. And this is from the Nature paper showing that META3 inhibition can actually treat, for example, ML, AF9 mutant leukemia. And it does so by downregulating translation of oncogenes such as MYC, HOX-A10, BRD4, and SP1. And so we're incredibly excited. We have their two compound. We also have an in vivo two compound. And as many drugs do, their META3 inhibitor is going to go into clinical trials first for solid tumors because hematologic disorders always have the problems of cytopenias already. But we're very excited to have this compound and really test it in MDS, and we're particularly interested in testing in splicing factor mutant MDS and AML. So for this purpose, we need really good models. And in MDS, the best model, mouse models are fine. Cells don't grow in culture, cell lines, are always a little questionable. We need really good PDX models or patient-derived xenograft models to study patient MDS. And for that, we also need samples. This is my second shout out really to the teams at Yale. So we have an amazing hematology tissue bank team really funded by the DeLuca Foundation. And then I have to really give a huge shout out to all advanced practice providers and fellows and some faculty for consenting patients and going through the work of, not convincing, but encouraging patients to donate their samples so we can study primary diseases. And we started this around 2011, and I probably was consenting people before that as a fellow and so on. And we have over 3,000 patients who have consented and donated their samples. We have over 8,000 samples. And there's amazing research going on in all of hematology and across Yale using these samples, which we're very excited about. So Natalia briefly mentioned, being at Yale, I wanted to study MDS, and I was still a fellow and going into the mouse room and doing the experiment myself. But Richard Pavel's lab has developed these incredible humanized mice that express human cytokines instead of mouse cytokines. So the human cytokines are locked in, they express physiologically. And they really designed these mice to study malaria and HIV, funded by the Gates Foundation. But it turns out all these cytokines, of course, are essential for hematopoiesis. So they're absolutely amazing and supporting human hematopoietic stem cells in human differentiation. So a while ago, we published on, engrafting MDS into these so-called Mr. G mice. And, we were able to engraft cells compared to all the other previous models very efficiently. We were able to show dysplasia. We were able to show really clonal fidelity. And we were also able to perform therapeutic testing. So we're now very excited of really harnessing treatment or modulation of the epitranscriptome to treat MDS and AML, and so delighted to stay in the world of RNA. And the immune system in these mice, human immune system in these mice is still problematic, but I think we also have ways potentially of now combining these therapeutics with checkpoint inhibitors or other immunotherapeutics. And so all this work is done by a lot of amazing people in the lab, former people, current people, the Human Tissue Bank, fellows who are contributing. And I thank you for your attention.
Thank you, Dr. Polina, for this exciting and fascinating presentation, really enlightening and so much highlighting also how much we don't know about hematopoiesis and hematologic malignancies and their origins of it. I would like to encourage the audience to come up with some questions, but maybe I could first ask you, how much is known about all these low risk MDSs with SRSF3 and others? What percentage of that is represented by some of these germline predispositions? And are we to look only into genome, or do you think that some of the spliceosome variants are potentially also inheritable?
Yeah, so the splicing factor mutations are not inherited, and probably because they wouldn't do well germline. So these are, even in the mice, are inducible mutations. So you can't have these as germline mutations. So they're really not predisposition. And really in the world of clonal hematopoiesis, they're also generally acquired later in life, right? So whereas you have TET2, DNMT3A, ASXL1 mutations, we think of, okay, probably start to find them around age 60 and up. SHF2, U2F and mutations occur later in life. So these are mutations in actually the splicing factors. But of course, the more we sequence and the deeper we can sequence, we can of course also find mutations now in specific splice sites of specific genes. But these diseases are probably so penetrant because with one point mutation in a splicing factor, you're now affecting splicing of a lot of different genes. So that's probably why they, are so effective at causing disease. Yeah.
Hi, Stephanie. I'm fantastic spot.
Thank you.
And I particularly enjoyed the part where we talked about NF-kappa B and how the NF-kappa B upregulation then leads on to translocation into the nucleus, transcribe a whole lot of other sites that then lead to malignancy. In terms of, I know NF-kappa B, NF-kappa B is inhibitor molecules. I'm not exactly sure how exactly the RNA factors into that upregulation of NF-kappa B. But in terms of for instance, the proteasome inhibitors, they are all related to NF-kappa B in some way, shape, or form in its modulation. So wonder if that might be another target where it would be RNA with the RNA technology to really target that regulation, upregulation essentially.
Okay, that is a complex question. So, so are you thinking about harnessing proteasome inhibitors in
Right,
this,
I mean,
or?
proteasome inhibitors do a similar. They go about it in a different fashion. They work on the eye-cupping mechanism to release NF, to basically releasing the NF. This is working in a different way, so I was quite intrigued by that. I mean, I'm probably going way off the track on this one.
No, I think there are amazing, really amazing opportunities. So I mean, just recently I was at the FACET meeting on RNA biology and cancer, and right, I have no research funding or stock or whatever, anything like that, right? But they're not small inhibitors potentially targeting MIP message and then preventing essentially degrading MIB message, and then you don't have protein. And that's, to me, is mind-boggling that you could use a small molecule to now target RNA. So I think there's a lot of opportunities to really, I mean, the other thing, of course, is antisense oligonucleotides, right? So right, you can use antisense oligonucleotides, right? You just have the sequence, and then you hope that if that antisense oligonucleotide finds its corresponding message, it can bind and then, for example, lead to degradation or lead to prevention of inclusion of that exon. I think, the difficulty of, right, we have again, Omar's lab also, right, use these splicing reporters essentially to, include these introns into, thymidine kinase, like a toxicity, right? The question always is, how do you now get these things specifically into cancer cells? That's always difficult. So that's, of course, where small molecules then have, you have to have a large therapeutic window. That's attractive, but I'm not at all in the development. I'm so looking at like basic mechanisms, omics.
Well, thank you so much for especially the overlay of just how, what's the word, diverse and redundant. I mean, you've got in terms of RNA, whether it's decreased or increased stabilization, it's in terms of splice sites and whether it's effects, you can just see the multiple layers at which you can then target different targetable sites throughout that whole system. So thank you.
I think that plasticity is also the reason we're actually all around, thank goodness.
Yes. Oh, yeah.
So I think it's good in health, and then in disease, right? We're challenged because now bad cells can also find a lot of ways around, but ultimately that redundancy, those many layers of regulation are also why I think we are alive. So even though we're not 20 anymore, so yeah.
Thank you.
Thank you, Stephanie. I learned a lot and learned a lot that I didn't know, so thank you. And I meant to say is I learned how much I didn't know. So I had a question about the stress granules. Are they a signature of all cancer cells or just the cells that have these splice mutations that you refer to?
So we found specifically in the splicing factor mutant cells. So we looked at SRSF2, UTF1, and also SRSF2. Other people have shown that in solid tumor. I think it remains to really the mechanism remains to be shown. I mean, all cells form stress granules. So you can take any healthy cell, stress with arsenic trioxide, and you get these stress granules, right? So what's in these stress granules in mutant versus wild type cells? Are they really a vulnerability, right? So this is basic laboratory science. So I think there's still a lot of work to be done. When we did this work, it's encouraging, right, that other people have shown it in cancer. So maybe it is a cancer mechanism, but it's also a mechanism that healthy cells need.
And I doubt that stress granules have been evaluated in the post-call setting after attending a consultation.
I have a lowbrow question. How does arsenic work in APL?
Okay. So, the PML, RAR alpha, I just taught the residents. But the PML RAR alpha, right, the fusion protein, it's a dominant negative, right? So that fusion protein sits on the promoter of the differentiation genes in promyelocytes. And so now the differentiation genes can't turn on because PML RAR alpha sits there. When we give ATRA, we give it at super physiologic doses, and ATRA comes in and competitively displaces PML RAR alpha from the promoter region. Arsenic trioxide probably does some of that, but arsenic trioxide also seems to degrade the message. So not so much by stress, but I think really by, attacking this fusion protein, degrading it, and many other mechanisms that, I probably couldn't explain everything to you. It's amazing therapy, being on service right now, I get to watch arsenic and the beauty and the dangers of it.
Comment?
I can hear you, or I just ignore you. If I don't like the person.
I guess you can ignore it. So just a comment, there are many RNA splicing mutations and alterations in diffuse large B-cell lymphomas, in mantle cell lymphomas. We have trials ongoing. We all have approved 2 patients with IRAK4 inhibitors in the clinic. I think it's too early to say whether it will pan out or not. But I wonder if it's better to study this more comprehensively by looking at various models, because this is a very fundamental mechanism. Sure, I think there is something to do with this dysplasia itself, but it's a quite fundamental mechanism which could happen in any cancer cell.
Yeah, no, I think you're totally right? So, and that's kind of what I highlighted a little bit in one of the slides. So SF3B1 mutations in RARS or MDS with ring sideroblasts, good prognosis, defect, in iron metabolism. And then it occurs also in CLL, and it's not good prognosis, and it occurs in uveal melanoma. And SF3 mutations don't really occur anywhere else. UTF1 mutations occur in lung cancer, right? And so, obviously, these are being studied by many labs, right? So I'm a hematology lab, MDS lab. But I know you were in a lymphoma lab, and we could certainly study this in CLL. But the question always is, right, so how do these mutations, why do they occur in these specific diseases? Why do they give that phenotype? But then also, why are they cancers? Why, right, when we look at patients with MDS and you sequence, right, the variant allele frequencies are really high, 40%, over 40%. And I could tell, the people always ask me, oh, when you graft these mice, when you treat the mice, do you get normal stem cells back? And so like, what normal stem cells, right? I don't find a normal stem cell in the mice. Meaning, right, but do patients still have normal stem cells, So I think these mutations do different things at different stages in the cells, right? They do different things in the stem cell than they do in their erythroid progenitors, So I totally agree. We need to understand, well, what is a more common mechanism in hematopoiesis? What is a mechanism in other diseases to really understand how we target them? And I had some other idea. Yeah. For example, DDX41 is a really, really interesting mutation, right? But when they're double mutant, you can't find cells, because it's in rare cells, or VEXAS syndrome, We call it MDS, but really, is it really MDS? Maybe not, but you have these inflammatory cells, the lymphoid cells die, the myeloid cells are now inflammatory. just because we can't we can't yet target that mutation, we can't correct the cells. There's not really malignancy to date, right? But the only cure is transplant. So we have a lot to learn, a lot to do, and I'm glad you're in the lab too.
Well, thank you very much for this amazing presentation. Thank you. All right, so with this, we will move on to our next session, which is presented by our experts in cellular therapy and transplantation team. And person who's going to moderate this session is everyone's favorite, Dr. Stuart Soropian, our seasoned clinician and expert in transplant and cellular therapies. And he's joined by Dr. Barr, Dr. Gouda, and Dr. Iris Isufi from the cellular therapy team. That might be there. This one is so we are notified for the panelists to be heard from the table.
Good afternoon. Nice to see so many familiar faces here today. Where's Dr. Chalice? Is he still here? I have to say, I'm very disappointed. I was expecting to have roast beef for lunch. So I'll find him later. So I'm excited for the last session here, which of course will be the most exciting, or at least I think so. We have a great panel of some of our faculty. I realized as I was thinking about introducing them that they come from all over the world. So they all came to their senses at one point in their career, and you realize that Yale is the center of the universe academically. We're very lucky to have them, and we'll start the first talk with Dr. Iris Isufi, who comes originally from Albania, did her medical training in New York, and then fellowship at Yale in hematology. And we were lucky to have her join the faculty. Iris is the clinical director of our CAR-T program. She's also an investigator in the lymphoma program, the phase 1 lymphoma program. And she's going to talk about cellular therapies for lymphoma.
Thanks for staying so late, everyone. Good to see you all. These are my disclosures. So I started, as Stuart said, as a stem cell transplanter, and as many of you know, many patients, for one reason or another, have a difficult time getting to transplant. And so when CAR T-cell therapy came about, we were all very excited because we were able to salvage patients who had had multiple lines of therapy and otherwise would have had very limited survival. So we started investigating CAR T-cell therapies in ALL and lymphoma, and then more recently in multiple myeloma. They all were initially studied in patients who had multiple lines of therapy. So for lymphoma, for example, they were first approved in the third-line setting, and then more recently, we've had approvals of 2 products that I've marked here in red, of axicabtagene ciloleucel and isocabtagene milalucil in the second-line setting. And this is a group of really high-risk patients with primary refractory disease or disease that relapses within 12 months of their initial upfront chemoimmunotherapy. And then since then, we've had approvals in mantle cell lymphoma, and we've had approvals of at least a couple of these products in follicular lymphoma as well. So just very excited to see where the field is going, and then 2 approvals in myeloma that Nofar will cover. So in the second line setting, so for a very high risk group of patients, we now have a randomized phase 3 study that was published in New England Journal of Medicine just last year that conferred overall survival advantage over stem cell transplant with 54.6% overall survival compared to 46%, which was statistically significant. There is a group of patients that is older and has comorbidities who may not have such aggressive disease that's primary refractory, may actually be a group of patients that relapse later, but they're not candidates for stem cell transplant. The criteria we use for transplant are more stringent than those we use to determine if a patient is eligible for CAR T. So there is this study called pilot study that was phase 2, looking at lisocabtagene maraleucel in the second-line setting for patients with relapsed refractory large cell lymphoma who were not candidates for stem cell transplant. And so these were patients that were over 70, that had a poor performance status, that had a decreased pulmonary function reserve, had low ejection fraction, low creatinine clearance. So patients that were not able to make it to transplant, and they were able to go on to CAR T. And just now at ASH, they presented the final analysis of this phase 2 pilot study. And this is rather small, but you can see that the overall response rate was very high, 80%, 80.3% for this elderly group of patients with comorbidities. And their complete response rate to CAR T was 54.1%. And the responses were actually very durable. So at 18 months, about 53% of these patients still maintain that response. Clinically speaking, we consider them cured, because if they go on for at least 2 years post-CAR T therapy and haven't relapsed, we know that the majority of those patients go on to maintain that response. So again, this is a group of patients that would have had really poor outcomes once they progressed after 1 or 2 lines of therapy and were not candidates for stem cell transplant. So the median age was 74 years, but you can see that at least in this study, they were up to 84 years of age, and we've treated them in the clinic, and actually there is institutional experience with patients who are in their 90s as well, who have gotten CAR T cell therapy. So another very exciting treatment modality is the bispecific antibodies, which have a different target than CAR T, which targets CD19. These actually target CD20 and engage CD3 on the surface of the T cells. And there are currently 3 products that are FDA approved. So epcoritamab and glofitamab are approved in the 3rd-line setting now for relapsed large cell lymphoma. And then mosunetuzumab is approved in follicular lymphoma. And then there is extensive research experience with odronextamab as well, although not technically yet approved. There are some differences in the design of these antibodies and the number of epitopes they bind. But in addition to that, there are also some differences in the mode of administration, IV versus sub-Q. But I identified some abstracts at ASH that looked at outcomes with these bispecifics in the post-CAR T setting, so patients who relapse after CAR T. So EPCOR NHL-1 study had an expansion cohort for large B-cell lymphoma, and they looked at epcoritamab in patients that had at least 2 prior lines of therapy, and prior CAR T-cell therapy was allowed. And in fact, as you can see here, 39% of patients in this study had prior CAR T-cell therapy, and 75% of those patients progressed within 6 months of CAR T-cell therapy. So really high-risk group. So when we look at the results post-CAR T, we can see that the entire group was about 157 patients, and overall response rates were 63% with a CR rate of 39%. But when we look at CAR T-cell therapy exposed patients, you can see that the overall response rate was perhaps a bit lower, but not by much, 54%, and 34% of those patients achieved CR. And then in CAR T-cell therapy refractory patients, the overall response rates were 46% and 28% CR rates. So there is a chance still for these patients who relapse post-CAR T, and there's at least 1/3 of them that are responding to bispecifics and going into complete remission. And if you see on the right, particularly the patients who achieve complete remissions, for those patients, the remissions tend to be very, very durable. And they can maintain that response for 2 years out. Again, the approval is in the third-line setting for all comers, but it was very exciting to see that this data post-CAR T, because those were patients that had very poor outcomes, even with novel agents such as loncastuximab tesirine or Revlimid tafasitamab, which are also relatively newly approved therapies in the relapsed refractory setting. And then very similar results with glofitamab, which is another bispecific. This was a pivotal phase 2 expansion trial in patients with relapsed refractory large cell lymphoma who had had at least 2 prior lines of therapy. So this is administered slightly differently. Epcoritamab is given sub-Q. This is an IV bispecific. It's given with obinutuzumab pre-treatment to mitigate the risk of cytokine release syndrome. And it's given for a maximum of 12 cycles, and then you can stop. So when we look at this particular patient population, you can see it's heavily pretreated, and about 33% of patients had had a prior CAR T-cell therapy, and 30% were refractory to their CAR T-cell therapy. What we were able to see is that the overall response rate was 52% for all comers, but in patients that had prior CAR T, overall response rate was also pretty respectable at 50%, and CR rate was 40% overall and 37% for patients who had had prior CAR T. And interestingly, the 2-year duration of complete response was 55%, so very durable, particularly for patients who achieve that complete response. For patients who unfortunately do not have a response to bispecifics, then their outcome remains extremely poor. So this agent has also received approval last year for relapsed refractory large cell lymphoma after 2 prior therapy lines. So what about sometimes people call me, they want to refer the patient, and they say, well, can I give the bispecific pre-CAR Ts that are going to affect the outcome? We know we all shy away from using certain antibodies, for example, like tafasitamab that already targets CD19 because we're worried about downregulation of CD19. So this was the study that looked at exactly that. The concern is that there could be potential T-cell exhaustion after giving bispecific treatment, and that might affect subsequent CAR T-cell efficacy. And is there actually an impact of the interval between the last dose of the bispecific antibody and the time that we apheresis the patient and collect the T-cell? So they looked, this was retrospective in nature, but they looked at 47 relapsed refractory patients that were treated with CD19 CAR T-cells who had had exposure to bispecific antibodies prior to their apheresis. And they had a control cohort from patients that were included in this European DCAR-T registry, and they did 1-to-1 propensity score matching. And what they were able to show was that previous exposure to bispecific antibody treatment actually did not have a negative impact on survival outcomes after CAR T-cell therapy. And that even if they did not respond to their bispecific antibody, that did not predict for a lower response necessarily post-CAR T. What about giving CAR T cell therapy to patients who are in complete remission? So this happens sometimes where patients have very rapidly progressive disease and we collect their T cells and then we give them bridging therapy. And then lo and behold, unexpectedly, they go into complete remission. So there was an initial reluctancy to give the CAR T cell infusion because we were worried whether the cells would expand. And so this is CIBMTR analysis where they looked at 134 patients. And these patients received several different products. They T-cell, axi-cell, lysocell. They had had several lines of therapy, so it was given both in the second and third line setting. And you can see that the progression-free survival and overall survival was 43.5% and 63.8% respectively. And this is not very different from what we would typically expect when we administer CAR T for patients with some amount of residual disease. It's important to note that there was a non-relapse mortality of 9% at 2 years. And while the majority of patients still died of relapse disease, there were patients that died of infectious complications, particularly COVID-19. And so it's really important to follow these patients long-term and keep them under surveillance to make sure that we give them growth factor support and appropriate antibiotics and antiviral treatments. So this is doable, and this is what we do at Yale, although some institutions delay the collected product until the patients show some signs of progression. So I'm just going to briefly switch gears now to mantle cell lymphoma, because this was also a disease where, you know, when patients fail their upfront chemotherapy, transplant, and a BTK inhibitor, the duration of response to subsequent therapies is relatively short. And so there are 2 studies, ZUMA-2, that looked at patients with relapsed refractory disease who had had up to 5 prior regimens, including a BTK inhibitor, who got Brexucel. There were 68 patients in that study, and it has now very long follow-up of 47.5 months. And then ZUMA-18 had 2 cohorts. It had a cohort of patients that received Brexucel when it was still not commercially available, and then another small cohort for patients whose manufactured products did not meet commercial release specifications. And that group, ZUMA-18, had 23 patients. And what we see is that with a long follow-up now, the median overall survival in ZUMA-18 was not reached, and 58% overall response rate at 24 months. And even from the ZUMA-2, with 4 years of follow-up now, patients continue to benefit from Brexucel with a median overall survival of almost 5 years in patients with complete response. So very durable, considering that these patients had had anywhere from 3 to 5 lines of prior therapy. So this has really dramatically, I mean, I have patients in clinic that have had even more lines of therapy, 7+, and are now 5 years out and still in remission following CAR T-cell therapy for mantle cell. So this was another interesting study. This is data from Stanford looking at patients who got CAR T-cell therapy at their institution, because the main toxicity of CAR T-cell therapy is cytopenia. And so there are patients for whom cytopenias can be very prolonged, particularly absolute neutrophil count and absolute lymphocyte count, and they have a high risk of infection. So the Stanford group looked at almost 500 patients who had had either stem cell transplant or CAR T. They had relapsed refractory diffuse large B-cell lymphoma, and they were in remission from their lymphoma. They did propensity score matching of patients who had had transplant versus CAR T, and they followed them over time. And they saw that at day 28, there were significantly more patients who had had CAR-19 therapy who had delayed neutrophil and lymphocyte recovery compared to patients who had had a transplant. The anemia and platelet recovery was similar. And in the CAR-T group, there was also a higher rate of grade 3 and above infectious complications as opposed to the stem cell transplant group, and increased non-relapse mortality. So they looked at marrow specimens for the patients who had available bone marrow biopsies that were probably done because of delayed count recovery, or where the clinician had a suspicion for a myeloid malignancy. And what they were able to find, so they identified a group of 21 such patients. And what they did DNA sequencing, and they were able to find a number of recurrent myeloid mutations that are typically associated with clonal hematopoiesis. And this is very small there to the right, but the majority of them, the most frequent was DNMT3A, followed by TP53, PPM1D, ASXL1, and TET2. And so 86% of the patients post-CAR-T had these clones of clonal hematopoiesis. And then 6 patients out of 21 actually had myeloid karyotypic abnormalities by FISH. And those patients went on to develop, those are in red to the left, a myeloid malignancy. The rest of the patients had the clones that did not develop a malignancy as of yet. And then when they looked to see, do these clones expand post-CAR-T, are they selected for, they identified a number of patients that had serial sampling of their blood, and they could look at cell-free DNA pre and post-CAR-T. And they found that particularly DNMT3A and PPM1D were selected for and clonally expanded. And if there was an over 5-fold expansion, they were able to show that that group of patients had the most delayed neutrophil recovery. So this is important because we can now potentially identify a group of patients pre-CAR-T who may have underlying clonal hematopoiesis, and where we can expect a delayed recovery in their counts and a higher risk of infections and non-relapse mortality. And we can also follow those patients more closely afterwards. And then I'm just going to end with just the final new safety notice that some of you may have seen from the FDA, where a draft guidance was issued because to monitor these patients for 15 years with the CAR-T therapy because of the potential risk for secondary malignancies. And just in December of 2023, the FDA actually became aware of 22 cases of T-cell cancers that occurred after treatment with CAR-T cell products. They were various different subtypes of T-cell lymphomas. And as you can imagine, it's very hard to go back and obtain tissue from all the centers and the physicians who treated these patients and then be able to test the tissue. So among these 14 patients, the cancers manifested relatively early. So within 2 years of administration of CAR-T, and half of them even occurred in the first year. They were only able to perform genetic sequencing in 3 of the cases, and they detected the CAR transgene in the malignant clone, which indicates that the CAR-T product was most likely involved in the development of the T-cell cancer. However, it's important to keep in mind that more than 27,000 doses of the 6 approved products have been administered, and that these numbers are extremely small, and we have to look at the indication for which we're giving CAR-T and what the survival of that patient would look like in the absence of CAR-T. And I think the field still decided that for a high-risk group of patients, such as relapsed refractory large cell lymphoma, this is, still worth pursuing while carefully monitoring these patients for development of secondary malignancies. And that perhaps as we extend now cellular therapies to non-oncologic indications, that perhaps we need to employ new strategies such as targeted insertion of the CAR construct to specific loci to reduce the risk of integration within the genome. So that's all I have. Thank you very much.
Thanks, Dr. Suki. That was great. I forgot to mention Dr. Suki holds the distinction of being our only faculty member who can fluently pronounce the name of all the lymphoma CAR Ts. The rest of us just use the trade names. So our next speaker is Dr. Barr, who for a returning engagement, Dr. Barr holds appointments both in the myeloma and our stem cell therapy group. She hails from Tel Aviv, where she started her medical training. Also, coincidentally, continued training in New York and got wise and came to New Haven, where she did her fellowship and joined our faculty. She's going to talk to us cell therapy for multiple myeloma.
Thank you. So I'm back. So I'm going to start with a loaded statement, and you'll understand why soon. But today, currently, CAR T-cell therapy is approved in the US for patients who are in their late relapse, as defined as 4 or more lines of therapy. We have 2 approved products, both targeting BCMA. The first one was ide-cel or Abecma, and the next was cilta-cel or Carvykti. And I have no disclosures. What I'm going to be, the abstracts that I chose today address specific themes or important questions in the field. Okay, so the first is, can we find predictive markers in terms of clinical factors or laboratory factors that can perhaps predict outcomes? Can we move CAR T-cell therapy in the earlier lines of therapy? And what about some new CAR T-cell targets? So this is a summary slide from the original KarMMa study that got ide-cel or Abecma approved in the late relapse, and this was approved in 2021. So the overall response rate is 73%. The median PFS is around 9 months, and median overall survival is about 19 months. With regard to toxicity, 84% had cytokine release syndrome, 18% had ICANS, the neurologic toxicity that we see with CAR T-cell therapy, and most patients had some level of infections, with 23% having serious or grade 3 and more infections. Some key patient characteristics that I want you to keep in mind as I move to the first abstract is here. So median age was 61. The median line of therapies that the patients had was 6. This was a heavily pretreated population, triple class refractory being 84%. That means they're refractory to an anti-CD38 antibody, an IMiD, and a proteasome inhibitor. And about a quarter of the patients were refractory to 2 IMiDs, 2 proteasome inhibitors, and the CD38 antibody. A little over a third of these patients had high-risk features like high-risk cytogenetics and extramedullary disease. So now I come to the first abstract that was presented by Sidani, which is the largest real-world data on ide-cel. And this was taken from the CIBMTR registry, and it was 821 patients. All patients that had conforming CAR products and adequate follow-ups were included, and they evaluated response rate, outcomes like PFS and OS, and toxicity, including secondary malignancies, as you heard, is a hot topic. So with regard to patient characteristics in this real-world data, I separated into patient-related, disease-related, and treatment-related, which is how we think about patients also when we're treating them. So this seems to be a slightly older population than what was seen with the KarMMa, with median age of 66, and a third of the patients were older than 70. ECOG performance status of 2 or higher was seen in 11% of the patients. In the KarMMa studies, there were 2% that had ECOG of 2. 77%, so the majority of the patients had some clinical significant comorbidity. And as you know, often significant comorbidities are excluded from clinical trials. With regard to disease status, these were not necessarily higher risk patients, with high-risk cytogenetics only seen in 27% and extramedullary disease in 17%. Treatment history, so median line of therapy was 7, a little bit more than 6. They were heavily pretreated, and 18% of the population had a BCMA, a prior BCMA-directed therapy. Mostly this is in the way of the ADC, antibody-drug conjugate belantamab. So looking at efficacy, looks very comparable to the KarMMa study. Overall response rate is actually identical at 73. Progression-free survival very similar at 9 compared to 8.8. And a 1-year overall survival estimate of 67%. The median was not reached. But here I want to focus on really why I'm presenting this is, can we find some factors clinically perhaps or in the lab that can predict worse outcomes? Can we find ways that we can tailor therapies to patients that would respond better and maybe do something different for patients that might not respond? So with regard to factors that predicted worse PFS and OS, as you see here, it's younger age, which is interesting, ECOG performance status of 2 or higher, a low platelet count, extramedullary disease, and high-risk cytogenetics, which is not a new theme. With regard to only predicting or associated with worse PFS, this is a high disease burden, measured as having more than 50% clonal plasma cells within the bone marrow, and then a shorter time from the prior BCMA-directed therapy to receiving Abecma. With regard to safety, CRS was very comparable. ICANS perhaps a little bit higher at 28 compared to 18% in the clinical trial. Maybe that's because this was an older patient population. There was 45% clinically significant infections, including bacterial and viral. And then small percentage of patients had secondary primary malignancies, and there are no cases of T-cell malignancy. Some factors that were associated with worse toxicity, so grade 2 or above, is having platelets less than 50, an older age, more than 70 compared to less than 60, and female sex, which I'm not sure what to make of that. In terms of factors associated with any grade ICANS, again, the platelets less than 50, older age, worst performance status, female sex, and significant comorbidity. So again, this is some factors that we should take into account. I think ideally, in the best world, is that we develop prediction models. We're certainly not even close to that, but this is some start. Now, next I'm moving to the second abstract, which is KarMMa-3, and this answers the question, can we move ide-cel earlier in the lines of therapy in the early relapse? So they included patients who had 2 to 4 lines of prior therapy. They had to be triple class exposed, IMiD, PI, anti-CD3 antibody, and they had to be refractory to the last line of therapy. So the phase 3 study was randomized 2 to 1 to ide-cel versus standard of care. You can see the different options for standard of care was per investigator discretion. There are many options. This is what we do in our clinic. We do different permutations of the available agents, usually switching classes or finding something they have not been treated with. Now, what's important here is that there was a crossover that was allowed. So if you got standard of care and you progress, the next line of therapy could be ide-cel. The objective here, primary objective was PFS, and secondary objectives were overall survival as well as response rate. Now, these results were presented and published, but what I'm showing you here is updated results really focusing on overall survival. So looking at the patient disposition, which is important because patients did cross over, you can see here in blue is ide-cel, gray standard regimens, and highlighted is about 50% of the patients in standard of care eventually then got ide-cel. So this is important when you're looking at intention to treat versus as treated population. These are the patient characteristics. We don't need to go into the details. What I want to highlight is that this is primarily a daratumumab refractory patient population with a median of 3 lines of prior therapy with some pretty high-risk features. So a quarter of the patient had extramedullary disease and a quarter had ultra high-risk cytogenetics, meaning 2 high-risk cytogenetics, which really portend a very poor outcomes in this patient population. And you can kind of get a sense from here, you see the median time from diagnosis to screening is about 4 years. And I mentioned this before in my prior talk. If you are able to get median of 3 lines of therapy in a shorter period of time, that means you are more functionally high risk. So sometimes very hard to treat patient population. So again, efficacy here that I'm showing you, not new. Response rate, much better. Overall response for 71 versus 42. Progression-free survival benefit, almost 14 months versus 4.4 months at a median of follow-up of 31 months. Now, overall survival analysis will be confounded by the crossover because more than half of the patients crossed over. So in the intention to treat population, the hazard ratio was 1, really is not different. But if you do a sensitivity analysis for the crossover, you do see an overall survival benefit of ide-cel reaching 41 months versus 23 months, so almost doubling the overall survival. And currently, the FDA is evaluating both ide-cel in earlier relapse and cilta-cel in early relapse. And we're probably going to find out in a week or two with very initial promising FDA messages. Yes. That's why the initial statement was a loaded statement. So this brings me to my last abstract, which is looking for other CAR T targets. And we know the GPRC5D target that we use with our bispecific T-cell engager. So this is also being used in research for the CAR T. And this is a BMS product, 986393. It is looking at patients who had 3 or more lines of prior therapy, so this for a later relapse, and prior BCMA-directed therapy was allowed, including CAR T-cell therapy. So ultimately, they did the dose escalation, dose expansion. Ultimately, they reached the recommended phase 2 dose being 150 million CAR T-cells. These patient characteristics in the 84 patients, very high risk patients, I would say 40, a little less than half of the patients, high risk cytogenetic extramedullary disease. Majority were triple class refractory and a quarter pentadrug refractory. Highlighting here that a little less than 50% had a prior BCMA directed therapy, mostly being CAR T-cell therapy. And 20% are BCMA refractory, which is kind of a new class we're seeing now. So this is a safety profile. The most common grade 3, 4 toxicities are cytopenias. This is not new. We see this with all our CAR T products. What they showed you here is the median time of resolution of the grade 3 cytopenias is about 46 days. Looking at the non-heme toxicity, CRS was seen in about 76% of the patients, and this is all treated patients versus the recommended phase 2 dose on the right. ICANS was seen in really minority of the patient, 10% overall. What you see in the phase 2 recommended dose, that none of these patients had either grade 3, 4 ICANS or CRS. Now, what's a little bit different here is they did develop these non-ICANS type neurotoxicity, up 11% overall and up to 15% in the recommended phase 2 dose, with 4% being grade 3 or above. They also had these very specific GPRC5D related AEs, including dysgeusia, skin and nail changes. We see this less frequently with the CAR T than we do with the bites. The bites we saw around 70%, more than 70% of the time. Here, dysgeusia being the most common, 25 overall and 30% in the recommended phase 2 dose, which I can arguably say that is the most distressing side effect for the patients. What is nice that these side effects did resolve in a median of 25 days, so that's nice. But let's talk a little bit about this non-ICANS type neurotoxicity, which is kind of cerebellar in nature. So they develop dizziness, ataxia, dysarthria, and nystagmus. It is dose dependent. There's no clear timeline from CAR T, but it usually occurs post-hospitalization. No clear relationship with expansion of CAR T cells, CRS, or ICANS at this point. The CSF has been really bland. And follow-up to date showed some signs of reversibility. So more to come on this. I think with the etiology of this is really not clear. This was reported that other GPRC5D CAR T cells from the Memorial Sloan Kettering group a few years ago. So this does seem to be a factor of this kind of class of drugs. So looking at the efficacy, the response rate were quite high. You can see here, overall response rate in the recommended phase 2 dose is 91%. And patients responded whether they had a prior BCMA therapy. And again, this was mostly CAR T versus not. Those that had prior BCMA see 100% response rate. And also, if you look at high-risk features, extramedullary disease, high-risk cytogenetics, triple-class refractory, all had overall response rate in the 80s. So this is something, again, to highlight that we see these very nice responses in very high-risk patient population with the GPRC5D products. The median duration of response was 13 months at this point. So this is still in investigation and hope to hear more about it soon. And that's where I end.
So our last presentation will be by Dr. Lohit Gowda, who's a faculty member in our transplant and cell therapy program. Dr. Gowda started his medical training in India. He also coincidentally came to New York and did more training there, did fellowships in both blood bank, and then went on to Texas to do a transplant fellowship prior to coming to New Haven. He is an investigator in our program interested in myeloid leukemias and complications of stem cell transplant. He's going to talk to us about transplant abstracts from the meeting.
Thank you, Stuart. And for those of you who have not known me, this is the 4th year I think I'm doing it. I'm always the last speaker. And Stuart tells me that, you know, at the end of the day, where do everybody go? They have to go to an allo transplanter. Like she just showed us how CCUS goes on, and she told us cytopenias are a problem. I don't know where my leukemia colleagues are hiding, but I'm ready for a roast. With that, let's get going. All right, so here are my acknowledgements. I have no real conflict of interest. So the first transplant was done about 70 years ago. I'm talking about the allogeneic stem cell transplant, right? Everybody here today has convinced you that you can manipulate the stem cells, peripheral blood cells, or immune cells, but they're only playing with their own cells. I'm here to convince you all that's not the way in leukemias. We got to take care of other patients, other donors' stem cells, implant it, and that's the way forward. And let me tell you what. So, as I said, we've known this for so many years. Cure is well-known entity with bone marrow transplants, but we do encounter relapse as a common problem, not as common as in the non-transplant setting, but it is an issue to tackle. Sometimes in our hyper-enthusiasm, the immune system plays up and leads to a complication called graft-versus-host disease. If you can tackle that significantly, then both the morbidity and mortality following a curative intent transplant gets better. Oftentimes, and I see a lot of pharma friends here, one of the ways you guys develop drugs is to say that these patients are not transplant eligible. So we have to catch up for that. So what we've done is we've got to come up with a very charming study called the CHARM study and tell you what would make that appealing prospect for more patients to be considered for transplant. And finally, there's a big fish floating around here. And let me come to that at the end of it, what I mean by that. All right, so about 30% of acute myeloid leukemia patients have a mutation called FLIG3. There are about 3 or 4 drugs now that are made it in the landscape. One of them in the relapse setting and 3 of them in the upfront setting, starting to be used at the time of induction, continued all the way post-transplant. But this study was looking into a compound called gilteritinib at a dose of 120 milligrams, comparing it against a placebo. These are patients who are FLIG3, a positive AML, and received intensive induction. At first CR, were eligible to go to transplant. I don't know how many curves have you seen like this since morning in AML. 80% of the people with FLIG3 AML in modern times are cured, right? Did you see any curve like that? I don't know. I'm not sure. Maybe I'm missing. But that's just a part of it. However, the statisticians spoiled our plan here. If you look at the top left column there, the study was designed in such a way that if we're going to use this drug called gilteritinib, it's meant to decrease what you call the relapse-free survival. The p-value there was 0.0518. So close, so far. It didn't mean the primary endpoint, but transplanters are always stubborn, we never give up. So we went back and dug deeper into the data to see how does this play out. It turns out, despite our best efforts to use FLT3 targeted therapies and intensive chemotherapy upfront, about 50% of the patients still have what you call measurable residual disease. And the higher the level of sensitivity you have, the better it gets. When Dr. Lewis and the rest of the colleagues looked into this, MRD does retain a prognostic significance, but also the kind of assay that we do, the highly sensitive one, seems to be able to differentiate people into different risk factors. So what we've learned from this MORPHO trial as of now in summary is that for patients who are peri-transplant MRD positive, continuation of this drug in the post-transplantation setting leads to significantly better outcomes. If they are MRD negative in the peri-transplant context, what I mean by peri-transplant is just prior to the transplant, and the drug is meant to be started. So if you're MRD negative prior to the transplant, and or MRD negative 60 to 90 days post-transplant, that's what I mean in a peri-transplant context. In that context, we're anticipating that we may be able to get approved, especially for the subcohort of MRD positive in the context of transplant. This is the second study. As we all know, leukemia is a common age that we are diagnosed. The problem is somewhere in late 60s, early 70s. One of the reasons they can't get to that is because the functional status is not that good. Allogeneic transplant employs a high-intensity chemotherapy. Not many patients can tolerate that. Lower targeted agents are helpful, useful, but relapse is a common problem. When we have to select patients for transplant, historically, we've used something called the HCT comorbidity index. This was a model that was developed from Seattle group, and there were some contributions from Dana-Farber. But those were all single center studies that are looking into integration of certain patient variables in a retrospective model to see how we can assess risk factors for patients who may be eligible for transplant, and then stratify the risks of non-relapse mortality and overall survival. As increasingly our population is getting older, what constitutes a good functional health of an individual in the older age remains challenging. The historical models of what we call the KPS or ECOG are good, but I think if you do it on a Monday morning, or rather I did all that same score on you before lunch and after lunch, it's probably going to be different, right? So what we need to do is continually get those scores monitored, not just functional. You also look into the social, intellectual, and other parameters that needs to determine who are these patients that can perhaps still be considered for bone marrow transplant. So BMT-CTN 1704 was basically an effort that was led by the Transplant Consortium to look into and develop prognostic markers that may be helpful in assessing patients who are at higher risk of non-relapse mortality, and also identify people who have differential overall survival. So here's a schema of how that study was done. So basically in the pre-transplantation context, patients come in anywhere between 0 to 21 days prior to the start of preparative regimen. We have to go through HCTCI, which is a scoring model that already exists. And there are some frailty phenotype scoring models now we need to look into. Lab test abnormalities are needed. And quality of life, patient-reported outcome monitoring system. That's a long list of questionnaires you need to do. And every time I'm running late in my clinic, my boss, Stuart, tells me that, catch up. He doesn't know I'm doing all of that. It usually takes 2 hours per patient, but then it's really necessary and helpful. I'm going to show that to you. And they also asked MDs, what do you think about looking at a patient? What is the prognosis for this patient, irrespective of what their functional status is? Because most of us seem to believe MRD and whatever else variables we have are the only things to go forward with. And then in the post-transplant period as well, at 3 months, 6 months, and 1 year, we repeat those things to see how does that variable change. And this was actually done to assess specific clinical outcomes of non-relapse mortality, survival, and GVHD. This slide is exclusively put up to show that despite an extensive list of variables to be tested, the investigators, we got to congratulate that there was a high compliance, almost close to 90% of all variables were captured in more than 1,000 patients. This is kind of a summary of what they were looking into: a cognitive assessment scale, HCDS scoring system, age, weight loss, CRP, albumin blood test, and KPS is one of the other models. As expected, there are no surprises here, right? Albumin, age, CRP, the directionality kind of tells us which way the NRM is going. I don't yet have a formula, but the investigators have promised us at the time of publication we'll have this, and we're looking forward to that. It also turns out we did find out what the risk of NRM is based on this, and we're able to stratify patients' overall survival by utilization of this. I'm waiting for the full publication, but this was just the abstract that was presented. The second option that anybody that pursues transplant, and it's a common question that I get asked in the clinic often, is what are my risks of graft-versus-host disease? And I see a lot of my former colleagues here who've invested significantly in this space to make both the survival and the comorbidity factor a lot better for our patients. We currently have 3 FDA-approved drugs: ibrutinib, Jakafi, and belumosudil. In order to expand further on that, the Agave group are now looking into an additional molecule, which I'm going to talk about. But prior to getting there, I just want to emphasize that, as shown on the right-hand side, steroids remain the major dawn in controlling chronic graft-versus-host disease. And after that, we use the other 3 FDA-approved agents. But long-term steroids has multiple problems. And the more number of agents you use, efficacy starts to go down. Based on some preclinical models, CSF1R receptor-dependent monocytes and macrophages have been now shown to mediate inflammation and fibrosis. Axatilimab is an investigational compound that targets exactly that same receptors on monocyte and macrophages. And in a preliminary study had shown safety results. And hence, this was expanded across 3 continents. There were 3 test doses, 0.3, 1, and 3 milligrams per kilogram of the study at different schedules that were done. The study's primary endpoint was looking for objective response rates in individuals who had active chronic graft-versus-host disease and had received at least 2 or more than prior lines of systemic therapy. This is just a slide to show that since it's a contemporary study, all 3 FDA-approved drugs were used in patient population. And also, if you look through that, about 50% had more than 4 organ involvement, and about 80% of them had what you call the severe chronic graft-versus-host disease based on the NIH consensus criteria. The study, as was presented in the plenary this year, met primary endpoint, the 0.3 mg per kg, the lower dose. The overall response rate was about 74. What's shown at the bottom here is time to response is less than 2 months, which is an impressive feat in the context of chronic graft-versus-host disease, especially if you're trying it late in the game. The box here elicits that regardless of what prior therapy they had used, either is it ibrutinib, ruxolitinib, or belumosudil, the drug did have efficacy. Importantly, the spectrum of activity of this drug was across all different organs. GI seems to be one that's doing really, really well. However, the common sites like the eyes, mouth, lung, everywhere there seems to be activity. As shown in the red and the right there, people who had sclerotic manifestations were experiencing benefits as well, as was claimed by the investigators. One of the side effects I want to emphasize is that there seems to be some predilection for liver as an on-target effect. Let's see how it plays out in the real publication. And with that, I'll come to the last slide, right? Last couple of slides. So it's the end of our conference almost, and everyone's convinced you drugs are the way to go. I'm here to convince you cells are the way to go. And as a transplanter, I think we are having a whale of a time, right? But I told you there's a big fish in the game here, right? So what do I mean by a big fish in the game here? Some of my good friends in the farm will always say, oh my God, if not for that predatory whale, by now I would have 20 drugs approved. MRD positive drug, MRD negative drug. But in a leukemic ocean, transplant is the biggest beast. It can still get many people to safety and cure. While I've already shown you, we work very well in conjunction with the drugs in the Morpho study that you do a transplant, put them on post-transplant maintenance, the rates of cure and survival gets better, especially in the North American cohort of population. I didn't get into the full details of that. I also want to show you that we want to enhance transplant application to more people. It's spring. Some of you may be taking your kids out to, I don't know, cruises or something like that. You may be seeing Orca out there. In the transplant context, what does that mean? So we are now engineering cells differently than what we've traditionally done in the context of bone marrow transplant. The idea here is the same. Transplant works by using one of 3 principles. There's a beneficial effect of the chemotherapeutic agent that we use in preparative regimens prior to the bone marrow transplant. The lower the intensity of that, the higher the intensity of relapse. Everything else that we do prior to transplantation is what I call a non-myeloablative intensity or a reduced intensity regimen. At the time of transplant, we can wipe out the bone marrow. That gives a solid chance of keeping a disease in check. And then we restore it with allogeneic stem cells as a rescue. We still do that in this platform. Compared to some of the other models where we just traditionally put in the T cells, here we do an ex vivo T cell depletion and then put in a purified, highly precision-based T cells. Those are T regulatory cells and T conventional cells. On day 0, hematopoietic cells plus Treg cells are put in. On day +2, then we introduce the conventional T cells. This study was done by investigators in Stanford, mainly looking into fully matched donors, and Houston investigators and a few others have also explored this in the haploidentical setting, and that's why I showed you 2 ARCAs. They're not one, but I'm only talking about 1 ARCA. Is that when they did that, and hopefully I can show you the curves out there, it's a comparison they did for patients who are 55 or older who got this approach. The survival rates are probably about 85 to 90%. What the investigators are claiming is, although these people are greater than 55 years of age, right, and most of those people are able to receive ablative transplant and not suffer the sequelae of chronic graft-versus-host disease. The reason is that now we're infusing a very purified subset of T cells. And by manipulating the graft in a different way, we are also able to decrease the rates of infectious complications, which is giving us better survival. So with that, I want to conclude saying that allogeneic transplantation retains a significant promise in modern era. When drugs don't work, cells always come handy. We do have some problems, and that's still a work in progress. Thank you very much, and I'm now open to your questions.
All right, questions?
What did they exactly do to purify the material? What's the technology? Can you give us some detail about that?
Yeah. So the abstract hasn't mentioned what it is, but I can give you a brief insight. So regulatory T cells, unlike in most of the cancers, right, regulatory T cells are bad because they increase the relapse. In bone marrow transplant, we need higher regulatory T cells because it leads to what's the word in that? There's always good relationship between the donor and the recipient. That's what we need. Regulatory T cells decreases the probability of developing GVHD. What they do here is by taking out the T cells first, right? It's a CD34 selected graft. Then you get the negative fraction of the T cells that you take in. We've done many versions of this in the past. Sometimes it's the pan T cell depletion, sometimes it's called the alpha beta T cell depletion. Now, the foolish version is use the beads to separate regulatory T cells versus conventional T cells, using the markers and the beads to those things. And that's what I think they've done, but it's not out in terms of what is the exact method. Yeah, and that method is not there. So they're claiming it's a central lab. The vein to go time is about 72 hours across the country, so it can easily be done. So it's a cell therapy graft manufacturing. I don't have the full detail, but I'm waiting for the publication. Thank you.
A question for Iris. So now in the world of lymphomas, it's a problem of choice, especially for large cell lymphomas, especially with bispecifics. And the data that you showed that bispecifics work, CAR T cell therapy still works even after bispecific therapy. And then you also talked about CHIP and post-CAR T cytopenias. So I wonder, and it's unlikely that in the field we're going to see a prospective trial of better patient selection for CAR T cell therapy to reduce the chances of post-CAR T problems. So I wonder, like, how do we, move forward in the clinic to choose the right patient? And one of the things I'm wondering would it be better before we make that decision of bispecific CAR T or not? Maybe these patients should get a bone marrow biopsy. Maybe we should be doing CHIP assays to see if they have CHIP or not, and then use that information now to figure out what should be the layering of or the sequencing of therapy that we do.
Yeah, so I think that's a very good question, critical for us to be able to answer in the upcoming years. The way I think about it right now, until better data comes along, is that we know that CAR T-cell therapy is able to cure the patients, at least 50% of them. You know, we've moved CAR T in the second line setting and shown a survival benefit. We don't have data with bispecifics as of now in the second line setting. We also do not have enough long-term data with a bispecific showing a curative potential. I mean, one of them is approved until disease progression, right? The other one is approved for 12 months. So we just need longer term data to be able to show whether bispecifics can indeed cure the same number of patients as we can cure with CAR T-cell therapy. So that's the first part. And then, you know, the other thing is, yes, and I think it's worthwhile, I know, to do bone marrow biopsies and look for CHIP. And I think there are institutions that do that routinely, even when they make decisions regarding autologous stem cell transplant, for example, for patients, because we do know that when we give them ablative regimen like Beam, then that could lead to clonal selection and expansion and a higher risk of myeloid malignancies. So I don't think we have enough information right now to support the decision of not taking a patient to CAR T because they have CHIP. I mean, as you can see, the majority, even though the numbers were small, the majority of those patients had clonal hematopoiesis pre and post CAR T, but did not have myeloid malignancies. And I think we just need to follow them long term as we are doing to see what's going to happen in the long run.
So there are patients who did not develop myeloid malignancies, that's correct. But I think all the patients that you showed there had cytopenias, correct? Or did I get that wrong?
So, yeah, I mean, those were selected for, they actually went and looked for patients to see the group of patients that post CAR T that had delayed neutrophil recovery.
Yeah.
And they specifically looked at marrows from those patients.
I see, so it was like retrospective in that
It was a retrospective in that setting, yes. So, and they were able to show that the group of patients that had delayed neutrophil recovery were exactly, the majority of those patients had expansion and selection of clonal hematopoiesis clones by at least 5-fold.
Okay, thank you.
Did you have some closing remarks?
Thank you, everybody. This was a fantastic session. I'm really, thank you, everybody, for attending. I really appreciate your presence and joining today, and really thankful to all of our speakers for delivering such high quality, very informative and thorough presentations. And I think more to come, and we should have more in-person meetings for perhaps for specific disease teams and some of the community events that we're contemplating currently. So thank you, everyone, for attending. And for those of you who are interested in obtaining CME and more credits, don't forget to text the Yale CME text message, and you'll receive the subsequent questions. Thanks, everyone. Bye.